Siddharth, I'll tell you something. I'll tell you one thing about the one shot program is like I need to finish the thing in like 4.5 hour, 5 hour max. Like if that way, if I think about it, so obviously there is filtration has to come. Blood vessels of upper limb, lower limb, yes, important. Blood vessels, anyways, anywhere are important because blood vessels surgery का एक integral part है. So obviously blood vessels are always important, whichever blood vessels. But I need to, again, I told you that when I look at the syllabus of anatomy, I need to look at, okay, if somebody is attending one shot and doing PYQs, will he or she be able to tackle at least 80% question asked in the exam in the anatomy? If my answer is yes, then the planning, the structuring I'm doing for this program is good. If I include everything in this year, तो बहुत बड़ा हो जाएगा ना. Then obviously it will be like regular class or a course which will go for at least 3 days or 4 days. So that's a different story. So you need to take it as a one shot only. There are things which are important and we still have to kind of miss out on them because they're not very important. Okay, chalo sir. Recharged and let's go. So in head, neck and face, guys, first let's talk a little about the cranial nerve nuclei and the columns here. I'll just give you a brief idea about these columns here and then we'll see that what kind of questions are to be asked from there. In the cranial nerve nuclei and column, if you're looking at this, the very first column, the general somatic efferent, GSE column, the first column, I'm just telling you in a very layman language, the first column is for extraocular and tongue muscle, the GSE. The second column is for pharyngeal arches, the muscles of pharyngeal arch. The third column is parasympathetic column, which I will discuss with you separately in detail. The fourth column is a nucleus of tractus solitarius, fourth and fifth column together, and this is for all the visceral sensation, taste, anything visceral sensation. The second last column is for all the somatic sensation, like the sensation coming from body wall. Pain, temperature, touch, pressure coming from body wall. The trigeminal nuclei is present in it. And the last column is for auditory and balancing, that is hearing and balancing, SSA column. The question asked in the exam is about the arrangement of the cranial nerve nuclei in the sequence. Now, again, there is no need to remember all the 7 columns here. Zarurat hi nahi hai. If you know the first 3 columns, you are still sorted in this. The first column is GSE, the second column is SVE, and third column is GVE. So if I know the first 3 column, I automatically know the next 3 column in a sequence. You just have to do the mirror image. Usko ulta kar dena hai. For the GVE, we have a GVA. For SVE, we got SVA. And for GSE, this is GSA. So if you know the first 3 column, then you just have to like mirror image like this and you look at the next 3 column here. And the only odd column, that is SSA column, special somatic afferent column, is present at the end. That is a SSA column, the special somatic afferent. So for the question which was asked in the exam, which was about arrange the cranial nerve nuclei column in the floor of fourth ventricle from medial to lateral, that is all medial to lateral only. What is the sequence here? Please do not spend your energy in remembering the 7 columns. Pehle 3 yaad rakho, you're done with that. You know the first 3, then you know the next 3 also, because that's like a mirror image. And the last one is an odd column, which will not match with any efferent column. That is SSA column is the last one here. Out of these columns, guys, the third nerve, oculomotor nerve, is present in the first column. You can see third nerve is present in the first column. And Edinger-Westphal is also the nucleus for third nerve. So third nerve is related to 2 columns. One is a GSE and one is a GVE. GSE and GVE are the column for the third nerve. Now, nobody in the exam is going to ask you what is the reason for the column, but you should know that at least parasympathetic nerve, I'm not saying all the 12 nerve, but at least parasympathetic nerve के column कौन-कौन से हैं? Third nerve, 7th nerve, 9th nerve, 10th nerve, the 4 parasympathetic nerve, what are their columns here? So third nerve column is first one, you can see it supplies extraocular muscle, and Edinger-Westphal is also the nucleus of third nerve, so that is the 2 column here. And for the 7th nerve, 9th nerve and 10th nerve, thank God, for the 7th, 9th and 10th nerve, we have all columns except first and last. Look at this highlighted column, guys. All columns except first and last. So leave the GSE, leave the SSA, and rest all the following columns are related to the 7th nerve, 9th nerve, and the 10th nerve, except the first and the last column here. Now again, nobody is asking you the reason for the column. You just need to know that which columns are there here. The question here is about knowing which column is not related to it. Which column is related to it? You automatically know it. If you know the first one is not there, last one is not there, then why would you like to know the thing like that here? This is all you need to know in this, कि मुझे पता होना चाहिए पहला नहीं आखिरी नहीं बाकी सारे कॉलम होते हैं. My job is done with that. Right? So third nerve nucleus, we have the first one and the third one, that is GSE and GV, And 7th, 9th and 10th nerve, guys, we have all columns except the first and the last, and you are sorted. That's it. You just don't have to do anything else in this. That is more than enough for the arrangement of the nuclear point of view. And I very strongly feel whenever the question is asked, it's about the parasympathetic cranial nerve, they ask you in that. Okay. Let's take this GSA column and GVE column in a little more detail, guys. If I talk about this GSA column, General Somatic Afferent column, the GSA column is having this big trigeminal nuclei present in that. One part is present in the pons, one part is in the midbrain, one part is in medulla oblongata also. The portion of this trigeminal nuclei present in the midbrain is called as a mesencephalic nucleus. Principal sensory nucleus is in the pons, and we have a spinal nucleus which is present in the medulla oblongata. But at DP, what is the significance of these columns? The significance of the column is it tells you that what kind of function the nerve is performing. If a nerve is having 5 columns, it tells you that the nerve is having 5 types of function. Secretomotor function, sensory function, taste function, blah, 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 whatever. Like different functions for the different nerve. That depends on the number of columns we have. Like third nerve is having 2 columns. So there are 2 types of function hote hain, to supply the extraocular muscle and to supply the smooth muscle. So that's why 2 columns are there. So significance is telling you the variety in the function of the nerve is holding. Mesencephalic nucleus, guys, it is for the proprioception. All the proprioceptive information will come to the mesencephalic nucleus regardless of where they are coming from and which nerve is carrying them. ऐसा नहीं सोचना है कि only the trigeminal nerve will come into it. No, nothing like that. Even a vagus nerve carrying the proprioception can come into it. Even the facial nerve carrying the proprioception from, let's say, facial muscle can come into it here. So it's regardless of the nerve. If it is a general sensation coming from the body wall, that will come into the trigeminal nucleus. Mesencephalic nucleus for proprioception. Principal sensory nucleus is for touch and pressure. All kind of touch and pressure will come into the principal sensory nucleus, the touch and pressure. And spinal nucleus, which is clinically very important, guys, it is for the pain and temperature. The pain and temperature sensation goes into the spinal nucleus. इसका example लेते हैं. Let's say trigeminal nerve, 3 branches, ophthalmic, maxillary, mandibular nerve. Now mandibular nerve is supplying this area, the chin area. So it's supplying the chin area here. Now, the muscle which are supplying the chin area, like the mentalis muscle and all that, the proprioception of these muscle will go through this same mandibular nerve only, but will end into the mesencephalic nucleus. If I touch here, or if I put a pressure on this area here, this sensation is carried by the same nerve, mandibular nerve, but will go into which nucleus? Principal sensory nucleus. But now, if I pinch here, I cause the pain. Or if I feel the burning sensation in here, that is pain and temperature, again carried by the mandibular nerve, but will go into what nucleus? Spinal nucleus. The nerve could be same, but the termination point could be different depending upon what type of sensation the nerve is carrying. It will go into the respective kind of nuclei. That is about the... Now, mesencephalic nucleus is a question which is asked in the exam more than once for the different reason, guys. Mesencephalic nucleus, first of all, it's a nucleus for proprioception. It is a center for jaw reflex also. When you test your jaw reflex, it is a center for jaw reflex, mesencephalic nucleus. And the special point, it is the only site in central nervous system having pseudo-unipolar neuron, guys. That's a very, very important point. Pure nervous system mein, we do not have pseudo-unipolar neuron anywhere else except for the mesencephalic nucleus. The only site for pseudo-unipolar neuron in central nervous system. Moving on, the next important column that we'll talk about is a GVE column, the third column, guys. GSE, SVE, GV. बस ये 3 ही याद रखने हैं. Rest I told you, will remember it. GSE, SVE, GVE. This is GVE column, General Visceral Efferent column, which is also called as a parasympathetic column. Because it is the nuclei present in there are connected to parasympathetic nerve and they are connected to parasympathetic ganglion. So this is going to be a very important slide, guys. We are kind of discussing a parasympathetic connection and we're also looking at the parasympathetic innervation of the glands also. Look, there are 4 nuclei in the GVE column. One is present in the midbrain, that is called as Edinger-Westphal, that is EW, Edinger-Westphal there. One is present in the pons, 2 are present in the pons, that is the superior salivatory nucleus, and we have inferior salivatory nucleus. And the one which is present in the medulla oblongata, that is called as the dorsal nucleus of vagus. That is dorsal nucleus of vagus. The nerve coming out of the Edinger-Westphal, the nerve for Edinger-Westphal is what nerve? Third nerve. Third nerve Edinger-Westphal nucleus se bahar aayega. And this third nerve will go and relay into the ganglion present in the orbit, and that is a ciliary ganglion. So guys, the ganglion for the third nerve is ciliary ganglion. And then from ciliary ganglion, the multiple short ciliary nerves will come out, and the job of these short ciliary nerves is to supply the smooth muscles, and that is sphincter pupillae and ciliaris muscle, right? So that's the whole parasympathetic pathway. Edinger-Westphal nucleus, third nerve will come out of it, relays into ciliary ganglion. From ciliary ganglion, the multiple nerves, short ciliary nerves, I did not write the name. The post-ganglionic nerves, you can simply say, the short ciliary nerves will come out and they will supply the sphincter pupillae and ciliaris muscle. Superior salivatory nucleus is a nucleus for facial nerve. Now guys, superior salivatory nucleus and nucleus of facial nerve. Now there are two branches of facial nerve which is required for the discussion. One of the branch of facial nerve is the greater petrosal nerve, as you can see the GPN. Greater petrosal nerve branch of facial nerve relays into the ganglion called as a pterygopalatine ganglion. It's a ganglion present in the pterygopalatine fossa, relays into pterygopalatine ganglion. And the post-ganglionic fibers from pterygopalatine ganglion will supply the lacrimal gland. That's the innervation of the lacrimal gland. That's one part. Another branch of facial nerve is called as cauda tympani. Cauda tympani nerve is also a parasympathetic branch. Now this will relay into the submandibular ganglion. And once it relays in the submandibular ganglion, the post-ganglionic fiber obviously will supply what gland? Submandibular and sublingual gland. So the name says superior salivatory nucleus, but the important thing is it is not only supplying the salivary gland, it is supplying the lacrimal gland also. If your superior salivatory nucleus or facial nerve for that matter is injured, then the loss of lacrimation will be there and loss of salivation from submandibular and sublingual gland is also there. Inferior salivatory nucleus is a nucleus for what nerve? Ninth nerve, glossopharyngeal nerve. Ninth nerve will come out of the inferior salivatory nucleus. Glossopharyngeal nerve, there is a branch of glossopharyngeal nerve called as Jacobson's nerve and all that. I'm not going to that detail. And it's the ninth nerve which is going to relay into the ganglion called as the otic ganglion. And guys, once it relays into the otic ganglion, the post-ganglionic fibers from otic ganglion will go and supply the parotid gland. By auriculotemporal nerve, they supply the parotid gland here. So by this, you can see that how third nerve, seventh nerve and ninth nerve are taking care of the smooth muscles and the glands, especially the gland part you think about, lacrimal gland, submandibular gland, sublingual gland, parotid gland, how they are supplied here. You know the preganglionic nerve also, you know the postganglionic nerve also. So this is very, very important. Dorsal nucleus of vagus, guys, it is a nucleus of vagus nerve only, and vagus nerve is not having a parasympathetic ganglion in head and neck. Vagus nerve के parasympathetic ganglion तो thorax और abdomen के अंदर है. So this is the one which is going to supply the smooth muscle and glands of thorax and abdomen here. So no ganglion here. It is like the ganglion are present beyond head and neck. So we have 4 parasympathetic nerve, we have 4 parasympathetic ganglion, but 2 parasympathetic ganglion are connected to facial nerve only. One is for the third nerve, 2 are for the facial nerve, and 1 is for the glossopharyngeal nerve. That is the parasympathetic. Parasympathetic nerve is 3, 7, 9, 10. Parasympathetic outflow. Guys, when I say parasympathetic nerve, that is 3, 7, 9, 10. If any nerve is supplying any smooth muscle or gland, that is a parasympathetic nerve. So obviously 3, 7, 9, 10 are the parasympathetic nerves. And apart from that, the sacral nerve, S2, S3, S4 are also parasympathetic nerve here. So it's 3, 7, 9, 10, S2, S3, S4 is called as a craniosacral outflow or parasympathetic outflow. Jabki T1 nerve to L2 nerve from T1 to L2, they supply the sympathetic supply, give the sympathetic supply. Thoracolumbar outflow is a sympathetic outflow. Dono question hai guys. Parasympathetic outflow is by craniosacral outflow, that is 3, 7, 9, 10, S2, S3, S4. That was the exact question asked in the exam, AIMS exam here. And that is T1 to L2. Nerve from T1 to L2 nerve, these are the sympathetic nerves. Whatever sympathetic supply we have in the body, it is all coming from T1, T2, T3, T4 or T12. L2 is the last. So 14 nerves. Overall, I can say 14 nerves in total are sympathetic. And look at these guys. 4 plus 3, 7 nerves are parasympathetic. The next picture that we have here is a transverse section of the neck, and this transverse section of the neck is telling us about the Dumpy fifth cranial nerve is actually not parasympathetic, but fifth nerve has a role to play in parasympathetic pathway because all the post-ganglionic fibers are coming via fifth nerve only. Till the ganglion, it's the third nerve, seventh nerve, ninth nerve. But after the ganglion, all these branches that you're looking at, they are the branches of fifth nerve which is reaching the gland. So I can say fifth nerve has a role to play in the parasympathetic pathway. Although it is not a main parasympathetic nerve, but it does participate in the post-ganglionic parasympathetic pathway. So guys, the next picture that we have is a picture of the deep cervical fascia. It's a transverse section of the neck here. And what we'll understand from this picture here, we'll look at this picture twice. First, हम इसमें nerve को identify करते हैं, and then we will identify the major spaces in that here, the topographic nerve. Okay. So let's get a quick orientation of this picture, guys. What you're looking at in this image here, this muscle here that is present on the posterolateral side, this muscle here is a trapezius muscle, and that muscle present on the anterolateral side, that is a sternocleidomastoid. Sternocleidomastoid and trapezius are the two big muscles of the neck. They are present anterolaterally and posteriorlaterally, and they are covered in this fascia called as an investing layer, guys. This fascia is an investing layer, this one here. Then the fascia which you see furthermore inside, which is covering the vertebral muscle, that is called as a prevertebral layer. The one which is covering the thyroid gland, again my hand will cut if I go beyond that, that is covering the thyroid gland, that is a pretracheal layer, and I'm pretty sure you can all identify the carotid sheath also in that, where the carotid vessels are present. Look, let's take them one by one. Okay, there are few circles which I'm like pointing at. I hope that you are able to see those circles in this animation. Like, there are 5 circles over there which are encircling the nerves. Look at the nerve which is present in the tracheo-esophageal groove, present in between the trachea and esophagus. That is a recurrent laryngeal nerve here. In the transverse section of the neck, they have asked this question to identify the vagus nerve, but there are very, very good chances they can ask you other nerves also to be identified. Recurrent laryngeal nerve कहाँ पर present है guys? Tracheo-esophageal groove. That exactly in the trachea and esophagus. Then the nerve that you see inside the carotid sheath, that nerve is a vagus nerve. The vagus nerve that you see running vertical into the carotid sheath, that's a vagus nerve. Then you see a nerve which is behind carotid sheath. Look at that. The one which is behind carotid sheath but in front of prevertebral fascia, and that is sympathetic chain. That is sympathetic chain. Sympathetic chain. And then the 2 more circles that you're looking at, those the animation you can see around them here. One of the nerve is present in front of scalenus anterior and one is behind the scalenus anterior. The one which is in front of scalenus anterior, that muscle is scalenus anterior between those 2 circles. The one in front of the scalenus anterior, present behind the prevertebral fascia, that is the phrenic nerve, guys. That nerve is a phrenic nerve. It is anterior to scalenus anterior but posterior to prevertebral fascia. PVF is a prevertebral fascia. And finally, the nerve that you see between scalenus anterior and scalenus medius, in between the 2, that is the cervical nerves which are forming brachial plexus. I told you the entire brachial plexus, the roots of the brachial plexus comes out between scalenus anterior and scalenus medius. So that's the cervical nerve which are forming the roots of brachial plexus. Dr. Bhavya, if you've written third nerve is also having a GSA, that is not wrong. I'll tell you why. Probably you are reading the note, the older notes only. It is believed that the third, fourth, and the 6th nerve, when they supply certain muscle, they also carry the proprioception from that muscle. That's the reason for that. Like third nerve will supply muscle, let's say it is supplying the inferior oblique muscle. So inferior oblique ka proprioception में लेकर आता है, and proprioception goes into GSA column. That's the reason you must have written that the GSA column is also there. But I would say, if I go with the recent trend and the recent question with the latest grades which was released last year only, 2 column. Just 2 columns, just check off this GSA column here. It's the GSE and the GV, the 2 column for the third nerve. Chalo, again, answering the question, देखो मैं topic से बाहर आ गया, I should not be doing that. So recurrent laryngeal nerve in the tracheo-esophageal groove. Vagus nerve is inside the carotid sheath. Sympathetic chain is behind the carotid sheath but in front of the prevertebral fascia. Phrenic nerve is behind prevertebral fascia but in front of scalenus anterior. और scalenus anterior और scalenus medius के बीच में क्या है? We have the roots of brachial plexus, the roots of brachial plexus. Let me put this picture once again, and this time I want you people to focus on 3 fascia I'm going to show you guys. Just behind the pharynx, guys, the fascia which is covering the pharynx from outside is a buccopharyngeal fascia. Look at that. I hope you can clearly see the fascia over there. That is a buccopharyngeal fascia. Then look at the fascia present in front of the vertebrae. That is a prevertebral fascia. This one is prevertebral. And then there is a fascia in between them also, and that is called as the alar fascia. Some author even call the alar fascia as the anterior layer of prevertebral fascia. वो इसको इसकी anterior layer भी बोलते हैं. Because if you ultimately look at that fascia, both the prevertebral fascia and alar fascia like kind of fusing on the side here, right? So buccopharyngeal fascia, alar fascia, and prevertebral fascia. The 2 major spaces. Between buccopharyngeal fascia and alar fascia, the space that you're looking at, that is a retropharyngeal space, guys. That space is a retropharyngeal space. And the one on which the question is asked here, between the alar fascia and prevertebral fascia, the space is called as a dangerous space of neck. Now, why we call it a dangerous space of neck? Because this space is open below. This space is not limited into the cervical region. This space is open below into the posterior mediastinum, and it is open till the diaphragm. That means any infection of this space, of this dangerous space of neck, it can go downward into the posterior mediastinum. It can compress the trachea and esophagus and can cause dysphagia and dyspnea also, guys. That's why it is called as a dangerous space of neck here. It can cause dysphagia and dyspnea, called as a dangerous space of neck. Yeah, it goes all the way to the diaphragm. Yes, correct. Okay, so The same section, but the previously we talked about the nerves, and this time we talked about the major spaces, the retropharyngeal space and the dangerous space here. Because they've already asked the dangerous space of the neck in the longitudinal section. Abhi kuch change karne ka time hai, so I'm pretty sure that they will ask you the dangerous space of neck. They might ask you in the transverse section. So please identify these fascias correctly in that. Let's talk more about this carotid sheath, because carotid sheath again is a question which is asked separately, guys. Chalo, from the black screen, let's go to the white screen here now. Now, carotid sheath, guys, let me take that carotid sheath out of the picture. Let us say this is a carotid sheath. Carotid sheath is having got artery inside. It's a common carotid artery is inside, and common carotid artery will continue as internal carotid. External carotid artery will come out of the carotid sheath. So when you talk about the content of carotid sheath, it's the common carotid artery and internal carotid, vagus nerve, and internal jugular vein. But look at this, guys. When we talk about the contents of carotid sheath, definitely these are contents. Common carotid artery is there, internal carotid artery is there, internal jugular vein is there, and vagus nerve is there. But you know, carotid sheath is attached above to the margins of the jugular foramen and also to the margin of the to the carotid canal. Abhi jugular foramen and carotid canal ke margin pe it attached. So if any nerve is coming out of jugular foramen, that is also supposed to be crossing this. Ninth nerve, 10th is anyways there. Ninth nerve, 11th nerve, even hypoglossal nerve coming from hypoglossal canal will cross this carotid sheath and will go forward here. What I'm saying, vagus nerve is definitely the main content of the carotid sheath. No doubt about that here. Like, let's say guys, if this is a carotid sheath here, vagus nerve is definitely passing through it here. But in the upper part, the couple of nerves are also crossing it here. Accessory nerve is going backward. Vagus nerve is going downward, obviously. Hypoglossal nerve is going forward here. So even 9th nerve, 11th nerve, 11th that is spinal accessory, and 12th nerve are also the contents of carotid sheath, or you can say it is traversing the carotid sheath in the upper part. If you have to choose one nerve, vagus is the answer, no doubt about that. But if the question is about what other nerves are also considered as content here, you're going to go with all the four cranial nerves, the last four cranial nerves, 9, 10, 11, 12, guys. Common carotid, internal jugular, vagus nerve, and as a 9, 11, 12 nerve, they traverses upper part. इसके upper part को traverse करके जाते हैं. So they are also the content momentarily only. The anterior relation of the carotid sheath is the ansa cervicalis. The ansa cervicalis which supplies the strap muscles. That is the anterior relation of the carotid sheath. And posterior relation of carotid. In fact, ansa cervicalis is adherent to the anterior relation. But posterior relation is a sympathetic chain. It is just relation, guys. Sympathetic chain is posterior relation, and we saw it earlier also. That sympathetic chain is present just behind the carotid sheath, but in front of prevertebral fascia. Between prevertebral fascia and carotid sheath, that is a sympathetic chain. Investing layer of deep cervical fascia, which is covering the entire neck. Now, investing layer, guys. Why do we call it investing layer? It is investing the entire neck. If a surgeon is approaching the neck surgically, you have to cross one fascia, जो आपको cross करना ही पड़ेगा, and that is investing layer, because it is covering the neck all around. Investing layer of deep cervical fascia is covering the neck all around, and it is called as investing layer because it is investing multiple structures. It is investing like two muscles, two glands. So there is a rule called as a rule of two for the investing layer. And what is the rule of two for the investing layer? Says that it encloses two muscles, that is sternocleidomastoid and trapezius, which you can see in the picture. It encloses two glands. One is the submandibular gland and even parotid gland, guys. Face is not having the deep fascia, but parotid gland is covered with a fascia, and that is made up of investing layer only. So remember, it's not the thyroid gland, it's a parotid gland block. Thyroid gland is present in pretracheal fascia. It's the parotid gland and submandibular gland in the investing layer. Another rule of two says the two ligaments of mandible, stylomandibular ligament and sphenomandibular ligament, are made up of this. Two spaces, one space of the sternum called a suprasternal space here, and there is a space which is above the clavicle called the supraclavicular space. These are the spaces which are formed in the investing layer, supraclavicular and suprasternal space. And there are two pulleys also. Well, obviously, which muscle will require a pulley, guys? The muscle which is having double belly. Digastric muscle को पुली का जरूरत है, omohyoid muscle को पुली का जरूरत है. So omohyoid pulley and digastric pulley are made up of investing layer. That's the rule of two for investing layer. Two muscles, two glands, two ligaments, two spaces, and two pulleys. Either they are made up of them or they are investing these structures inside. The rule of two for the investing layer. Okay, moving on from the deep cervical fascia. That was a major thing about the deep cervical fascia. The next important thing here is the dural sinus and the cavernous sinus is the most important in that, guys. You're looking at a coronal section of the cavernous sinus, and what you see in the cavernous sinus, first if I go with the lateral elevation, it's a coronal section, guys. Medial elevations are quite obvious. I don't have to tell you medial elevation is, you can see that sphenoidal air sinus is there, pituitary gland, you can see clearly there. What are the lateral relations of cavernous sinus? There are four nerves present in the lateral wall. That is the third nerve. We got a fourth nerve. We got a ophthalmic and maxillary nerve. Mandibular nerve is not in the lateral wall. So we have V3, 4, V1 and V2, ophthalmic and maxillary nerve. The only nerve which is passing through the cavernous sinus, having the longest intradural course also, and that is a sixth nerve, guys. That's a nerve with the longest intradural course, that is a sixth nerve, along with internal carotid artery. Internal carotid artery is also inside. Now, if internal carotid artery is inside, there is something interesting, guys. Internal carotid artery is the content, or it is inside the cavernous sinus. If there is any aneurysm of internal carotid artery, and let's say that aneurysm ruptures, what will it lead to? It will lead to the fistula called as a carotido-cavernous fistula. And because of this carotido-cavernous fistula, every time the internal carotid artery will pulsate, the entire cavernous sinus will pulsate, and it will also push the content of the orbit, and that causes the pulsatile proptosis also. If there is an aneurysm of the internal carotid artery, ruptures inside the cavernous sinus, that causes this pulsatile proptosis, guys. Look at this video here. You can see the pulsation of this eyeball. That is a pulsatile proptosis, not pulsating exophthalmos. It is pulsatile proptosis, and that is because of the rupture of internal carotid artery inside the cavernous sinus. Okay. Chalo. Moving on. The next thing we're going to discuss here is about the muscles of mastication. From the head and neck, this is a very, very commonly asked question about the muscle of mastication and their actions. So you got to be very precise about that. What are the muscles of mastication and what their actions are here. Now guys, first of all, look at this picture here. And the main reason I wanted to show you this animation here to understand that the muscle present outside, that is a masseter muscle you're looking at here, and the muscle which will be inside, that is medial pterygoid, their fibers are oriented in the same way. Although one muscle is outside, one muscle is inside, but their fibers are oriented in the same direction, and that's why their action will also be the same. Look at the masseter muscle here, and look at that muscle inside. That is a medial pterygoid muscle over there. So medial pterygoid and masseter. If you just compare both the muscle here, look at the masseter and look at that medial pterygoid muscle. Their fibers are oriented in the same way only. Although one is outside and one is inside, but that's why their action is the same. Their action is going to be the same. Like quite a few similarities are there in their action. Okay, let's take these muscles one by one. First, you're looking at the picture of the temporalis muscle here. And this is, I always say this, and I'll suggest you all you people guys, do not pay attention to the origin of the muscle. That's a waste of the time. Especially for the people who are preparing for the PGME exam. I mean, I'm not talking to the first year students here. For you people, what matters is the insertion. Insertion kahan par hai? The action of the muscle is decided based on the insertion point. Temporalis muscle ho, masseter ho, medial pterygoid, lateral pterygoid, every muscle is inserted on the mandible. They have to move the mandible. So obviously you need to see how it is oriented toward the mandible, and then you just have to see in the reverse manner that if the muscle contract, how it is going to pull the mandible. Like if you look at the temporalis muscle, forget about where it is originated. No, koi nahi puchne wala ki temporal fossa se aa raha hai, kahan se aa raha hai. It is coming from there. The temporalis muscle is inserted to the mandible in such a way that some fibers are vertically oriented, as you can see, and some fibers are going like anteriorly. That's why the fibers which are vertically oriented, they will cause the elevation of mandible. And the fiber which are horizontally, more or less horizontally oriented, they will cause the retraction of the mandible here. Elevation of the mandible is a strong action of temporalis muscle, but retraction of the mandible is a unique action of temporalis. Koi aur muscle, no other muscle of mastication can cause the retraction, only temporalis can do that. Elevation and retraction. Elevation is done by other muscle also, but retraction is not done by any other muscle. That's a unique action. So if you ask me, if the question is asked, what is the action of temporalis muscle? Will you write elevation or retraction? You will write elevation, guys. The major action is elevation. Retraction and protraction, ये कोई बहुत major action नहीं होते हैं. The main action of the jaw is opening and closing. So if you have to choose between the opening and closing and sideways movement and protraction, retraction, always go for opening and closing thing. Don't go for protraction, retraction, sideways movement. That is the main function here. But yes, if the question is asked that what is a unique function of temporalis which is not done by any other muscle of mastication, then retraction is your answer. Masseter muscle, if you look at this muscle outside, there's masseter muscle. Again, the muscle is oriented in such a way that the muscle contract. It is going to pull the mandible upward. So it is again the main muscle for elevation. It does help in protraction also. But again, protraction is a very, very accessory function. The main action of masseter muscle is elevation. It's a very strong elevator. It's a muscle for the clenching of the teeth. When you clench your teeth like this, you can feel the muscle outside here. It looks like a stone present outside. That's the masseter muscle. Then if you look at medial pterygoid, and I already told you guys, medial pterygoid and masseter muscle, the direction is same. Medial pterygoid is outside the ramus. If you cut the ramus and you see inside, look at that muscle over there. That is a medial pterygoid muscle shown over there. And medial pterygoid action, that's why it is also what? It also helps in elevation. Just like masseter, it is also helping in elevation. Both masseter and medial pterygoid, they does help in protraction also, but बहुत accessory function hai. The main function of the muscle is elevation. And then comes the very, very special muscle. 5 times there is an image-based question asked on the muscles of mastication. और 5 में से 4 बार this muscle is asked. That is lateral pterygoid. This is the muscle which is asked maximum number of times, and there is a reason to that. Look at that muscle here. First of all, talking about the question asked last year only, lateral pterygoid muscle, it extends, the tendon of lateral pterygoid extends in the cavity of TMJ as the articular disc. There is a fibrocartilage called as the articular disc present in the joint cavity of TMJ, and that articular disc is an extension of tendon of lateral pterygoid. So, एक question तो यही होगा, lateral pterygoid extension. Secondly, if you look at the two bellies of lateral pterygoid, the lateral pterygoid muscle is running horizontally. So the upper belly mainly helps in what? Protraction. And the lower belly will help in what? Depression. In fact, in one of the recent short videos which I am releasing nowadays on my channel, this lateral pterygoid is not actually the muscle for the depression. It basically brings the mandible in such a biomechanical position that the depression can be done effectively. जब तक आप mandible को protrude नहीं करोगे, unless you protrude the mandible slightly, then mandible will not come into the biomechanical position when the muscle can pull it down here. Actually, the muscle which are responsible for depression is not the muscle of mastication. It's the geniohyoid, anterior belly digastric. The muscle present here, they are the one which pulls the mandible downward. But the question is not about those muscles. The question is about these 4 muscles of mastication and their action. So let's look at this way, guys. Elevation or closing of mouth is done by what? It is done by temporalis also, masseter also, medial pterygoid also. But closing is done, opening is done by what? Lateral pterygoid. Okay. Protraction is done by which one? Protraction is by what? Lateral pterygoid. Retraction is by which one? The temporalis. And when it comes to the medial pterygoid and lateral pterygoid working ipsilaterally, only one side, the pterygoid muscle action working ipsilaterally is to deviate the jaw toward the other side. They rotate the jaw toward the other side. If I use my lateral pterygoid and medial pterygoid for right side, I will deviate my jaw like this. My jaw is deviated toward the left side. That is because of my right side pterygoids are working here. So they rotate the jaw toward the other side. That's about the muscles of mastication. From the muscle of mastication, the another important topic, guys, in the head and neck is a posterior triangle. Triangles of neck, all the triangles you need to know. Orientation, I'm sure the people who attended my lectures, they know that how important the triangles of neck are for the orientation sake here. But again, we're talking about the question point of view, posterior triangle. Nothing can beat the posterior triangle. And in the posterior triangle, the 2 nerves, which I always say the 2 most important nerve that is present inside, that is, one is the great auricular nerve, the nerve which is emerging from the posterior border of sternocleidomastoid. That is a great auricular nerve. Generally, people call it great auricular nerve. It's a great auricular nerve, guys. A very, very important nerve, which is again dividing into 2 branches, facial branch, mastoid branch, or anterior posterior. You can call it facial division, mastoid division, or anterior posterior division is there. And what makes this great auricular nerve so important? What makes the great auricular nerve so important, guys? The great auricular nerve, everything about great auricular. First of all, let me start with the root value. That is C2, C3, or maybe C3, C4. It's variation, guys. C2, C3 or C3, C4. I'm going to go with the C2, C3 in this case here. C2, C3 or maybe C3, C4 also. So C2, C3 is the usual root value for the great auricular nerve. Great auricular nerve, first of all, it runs with the external jugular vein. Look at the animation there. That's the external jugular vein on the side of the neck here. And the great auricular nerve runs with the external jugular vein. Neat mein question pucha hua, guys. That's one of the neat question only, that which nerve is seen running with the external jugular vein on the side of the neck. That's great auricular nerve. Another thing, exactly, it supplies the lobule of the ear. This nerve supplies the lobule, lower 1/3, guys. Whatever I'm holding right now, that is a lobule of the ear. So, when we go for the ear piercing, that when we are screaming there, that is because of the nerve which is causing the pain while the piercing of the ear is the great auricular nerve only. That is the lobule, supplying the lobule of the ear. Then this nerve is also responsible for supplying the skin at the angle of mandible and parotid area, and that is the shaving area that you rightly said. It's a shaving area, guys. The shaving area, because that was also a recent question asked here. So the shaving area, that is the angle of mandible and the parotid region, supplies that region. And then we have in Fraze syndrome. Now we know in Fraze syndrome there is injury to auriculotemporal nerve. Now understand this. In the Fraze syndrome, nerve kaun sa injured hua? Auriculotemporal nerve. Now when auriculotemporal nerve regenerates, it can join with some other nerve also. It can join with buccal nerve. It can join with lesser occipital nerve. It can join with great auricular nerve. But most commonly it joins with the great auricular nerve. That's why in Fraze syndrome, when auriculotemporal nerve, like when it stimulates, it is not only stimulating the parotid gland, it is stimulating the sweat gland also supplied by the auriculotemporal nerve in this region, this great auricular nerve in this region here. So in Fraze syndrome, the regenerating auriculotemporal nerve most commonly fused with great auricular nerve here. So look, all these different questions in there, and they're all about what only? The great auricular nerve. Or this sub question exam puche guys. All these questions are asked in the exam here, and it's one of them. Like in parotid surgery, the sensory loss in the shaving area, we already said parotid region is a shaving area only. They've asked this question once, that a patient 2 weeks after the parotid surgery came to the surgeon, and he complained that he's having a numbness and sensory loss in the shaving area or while shaving. So shaving but bada important hai yahan par. And that is obviously because of which nerve injury? That is great auricular nerve injury. But we are discussing the rule of 17 now. We're coming to that. Okay. Then look at this nerve, guys. The nerve which is actually coming from carotid triangle, passing deep to sternocleidomastoid and then supplying the trapezius muscle also, and that is the spinal accessory nerve. Apart from great auricular nerve, the second most important nerve to be remembered from posterior triangle is the spinal accessory nerve. Well, again, very important, guys. Spinal accessory nerve, we all know it supplies sternocleidomastoid and trapezius. Sabko pata hai? But the question is, when spinal accessory nerve is injured in the posterior triangle, when the nerve is injured in the posterior triangle here, in this triangle here, that means it is already supplied what muscle? Sternocleidomastoid. So sternocleidomastoid will be spared. Now, what are the functions of sternocleidomastoid? Like, if I demonstrate the function of sternocleidomastoid, guys, my right sternocleidomastoid will help me turn the face to the left side. So turning the face to the opposite side, that is the function of sternocleidomastoid. Tilting the head to the same side, that is also the function here. And the bilateral action of sternocleidomastoid will help in the flexion, and they also help in the protrusion of the neck like this. The flexion as well as the protrusion of the neck here. Bilateral action. Unilateral way, they are doing what? They are tilting the head to the other side, face to the other side here, and tilting the head to the same side. And if you try to perform both the function together, you will understand that why we have torticollis when there is a contracture of sternocleidomastoid. Because when there is a contracture of the sternocleidomastoid, both the function of sternocleidomastoid can be seen. That is what? Turning the face to opposite side and tilting the head to the same side. Like it looks like a torticollis only, guys. That is because both the function can be seen together. The muscle is contractured. If I'm facing like this, if agar main left side mein upar ki taraf dekh raha hu, so it is because of right side muscle torticollis here, right? But my point is that spinal accessory nerve, if it is injured in the posterior triangle, that means the sternocleidomastoid will be spared. So all these actions will be spared. The patient can see toward the left side, he can do the forward bending, he can do the lateral tilting, all can be done. Only trapezius muscle is involved. First, the question is, why am I talking about only spinal accessory nerve injury? Because spinal accessory nerve is one content of this triangle which is present quite superficially, guys. Generally, the most of the important content, the subclavian vessels, the brachial plexus, which are present in the posterior triangle, they are present deep to the prevertebral fascia. Dekho, neck mein we have investing layer, and after investing layer, there is a prevertebral layer. And then we have imagined brachial plexus and all that. So two fascias are there. But spinal accessory nerve, it is present between the investing layer and prevertebral layer. That's one thing, guys. This nerve runs between the investing layer and the prevertebral layer, and that's why it is vulnerable to injury also. Because the moment you open the posterior triangle, the nerve which is running superficial in this triangle is the spinal accessory nerve. And as I told you, that injury to the spinal accessory nerve in posterior triangle, sternocleidomastoid muscle will be spared and only trapezius muscle will be affected. And the features of trapezius muscle will be seen. What are the features of trapezius muscle? Shrugging of shoulder. So patient will have a difficulty in shrugging of shoulder. There's a difficulty in retraction of scapula. And there's a difficulty in overhead abduction also, because trapezius helps in the overhead abduction by rotating the scapula. these will be the chief complaint of the patient here. Difficulty in shrugging, difficulty in the scapular retraction, and difficulty in overhead. All difficulty, guys. Nothing is lost completely. There's a difficulty in all these action because trapezius is involved. The main point from where the question is asked from this area is that when spinal accessory nerve is injured in the posterior triangle, आपको ये ध्यान रखना है कि sternocleidomastoid is spared and only trapezius is involved. So you just have to go with these features only. That's the main catch. Moving on, coming to the cranial fossa, guys, there are two important foramen because they're asked in the recent time, or repeatedly they asked in the recent time. So I should tell you about those two foramen, guys. You're looking at the skull foramina here. Foramen ovale, spinosum, ये सब पढ़ते हैं, that I'm pretty sure that you all read about these foramen also. But the two foramen on which the questions are specifically asked here, one is the foramen lacerum, look at that here, which is present in the floor of cavernous sinus. And another foramen, that is the jugular foramen, guys. So first let's start with the foramen lacerum here. The one question which is asked about the foramen lacerum is that this foramen is present between what bones? The foramen lacerum is present between three bones. That is a petrous temporal bone. The bone that you're looking at over there is a petrous temporal bone. I'm again out of the frame. That's a petrous temporal bone. Then you have bone which is coming from the inner side, that is a occipital bone. You can see foramen magnum there. Foramen magnum wali jo bone hai, guys, that is a occipital bone. And the bone which is present anterior to foramen lacerum, just see that, anterior to foramen lacerum, that is sphenoid bone here. So sphenoid, petrous temporal, and the basioccipital or occipital bone. So sphenoid bone, petrous temporal bone, and occipital bone are contributing to the formation of foramen lacerum. What is there in the foramen lacerum? Now there are some contents which are traversing the foramen lacerum, which are crossing the entire foramen lacerum ऊपर से नीचे तक, crossing the whole foramen lacerum. One is the emissary vein, and we have some meningeal branches of ascending pharyngeal artery, the one which are supplying the dura mater, guys. We have meningeal branches of ascending pharyngeal artery because it could be a trick question here. Which structures are traversing the foramen lacerum through and through? And there are some contents in foramen lacerum which are not traversing it completely. They are just present in the foramen lacerum, पर वो कहीं और से आ रहे हैं. Like greater petrosal nerve will come somewhere else and will go into the anterior wall. Deep petrosal nerve, internal carotid artery will come from somewhere else and enter there. So these are the contents which are not the true content, guys, because they are actually the content of carotid canal or Vidian's canal, but they are momentarily present inside the foramen lacerum, and these are the fill-ups जो उसको fill कर रहे हैं. What I'm trying to say, let's say if this is a foramen, guys, let's say if I'm demonstrating, let's say this water bottle is a foramen. Now obviously the content of this foramen is a nerve or any structure which is passing through. Like my finger right now, it's in the inside bottle here, that is a content. That's a content of the foramen. And if I just take out my finger from the other side, it's a complete content. But let's say if I just pierce this bottle from here and then I come out from the upper part here, then I'm not a true content. I'm just filling it up. The content which is through and through or traversing it are only the meningeal branch of ascending pharyngeal artery and emissary vein, and these internal carotid arteries, sympathetic plexus, greater petrosal, deep petrosal are just the fill-ups only. The another important foramen on which the questions are asked in the recent time is the jugular foramen. Again, very, very important, guys, and I again personally feel very strongly for these two foramen. ये दोबारा फिर पूछेंगे exam के अंदर. This is a jugular foramen, guys. The jugular foramen, it is like oval shaped foramen here. First of all, jugular foramen is giving passage to the two formative tributaries of internal jugular vein. The two veins which together will give rise to internal jugular vein, or two sinuses which will give rise to internal jugular vein. One is the inferior petrosal sinus and one is the sigmoid sinus. These are the formative tributaries of the internal jugular vein. The moment they come out of the jugular foramen, they join together and they form. Then they give passage to the 9th, 10th and 11th nerve also. Correct only, guys. 9th, 10th and 11th nerve are also coming out of it. 9th, 10th, 11th nerve. And we also have some meningeal branches of ascending pharyngeal artery. Not a very major content here, but some meningeal branches of ascending pharyngeal artery are also coming from that. We saw the same artery we saw in this foramen also, jugular foramen. Ascending pharyngeal artery is giving off the meningeal branches which are entering from multiple foramen here. It enters through hypoglossal canal, jugular foramen, foramen lacerum. So these are the branches of the pharyngeal artery which are supplying the dura mater. And out of the 9th, 10th and 11th nerve, as we know, 10th and 11th nerve, they together forms the vago-accessory complex. So both these nerves are present in the common dural sheath, and it's the 9th nerve which is having a separate dural sheath, and that was the question asked in the INICT, that which content of the jugular foramen is having a separate fibrous passage. And separate fibrous passages for which nerve? 9th nerve. 10th and 11th nerve are best friend, guys. They are the one which are going to join together and then supply the whole world. So that's why 10th and 11th nerve, they are together forming the vago-accessory complex. It's the 9th nerve which is having a separate passage passing through the jugular foramen. So that's about the two important foramen here, that is foramen lacerum and the jugular foramen. Next picture that you're looking at is a picture of the cranial fossa with the durameter intact. A problem kya hota hai when the durameter is placed here, it becomes a little more challenging to identify the nerves. How will you identify the nerve if durameter is there? I cannot see foramen. Let me enlarge that marked area. Guys, if I enlarge this marked area here, what do you see? Look at that here. Now, this is the area of cavernous sinus. Let me just try to give an orientation for that. Guys, this is the area of cavernous sinus where my hand is placed here. Let's say this is the cavernous sinus area right now here. Now, in the lateral wall of cavernous sinus, we have third nerve. Look at this thin nerve over there, is a fourth nerve. And we have trigeminal nerve branches. That's the whole trunk of trigeminal nerve I can see, which will go inside and divide into ophthalmic, maxillary, mandibular. So all these nerves in this line here, look at this one line, guys. All these three nerves are present in the lateral wall of cavernous sinus. There is a third nerve over there, this one. That is a fourth. This thin nerve over there is a fourth nerve. And that is a trigeminal nerve, which will obviously divide into branches. Over there is a internal carotid artery, and you can see which is also can see a nerve over there. That, guys, this is the anterior clinoid process. I mean, again, I'm going out of the frame only. That is anterior clinoid process where my finger is pointing right now. That you can see the tapering process over there. That is anterior clinoid process. Only one nerve is seen medial to the anterior clinoid process, and that is the optic canal, and that's the optic nerve over there. Now, number 2. In the lateral wall of cavernous sinus, we have third nerve. We got this fourth nerve, the thinnest cranial nerve, the fourth nerve, and even trigeminal nerve is also to be seen here. And then look, the question asked in the exam was actually on this nerve, guys, the one which I'm pointing right now, this one or this one. Now, this whole slope here, this slope is called as a clivus. This is a clivus where the brainstem is present. Midbrain, pons, medulla oblongata is resting on this part here. And the only nerve that you see on the clivus is a sixth nerve, and that's the reason it is having a longest interdural course also. Imagine karo, nerve will enter into the durameter at this point only, and then it runs inside the cavernous sinus, keep going. So obviously the nerve is having the longest interdural course. So that is a sixth nerve, guys. Abducens nerve, it is the only nerve that you see on this entire slope, and that is the abducens nerve. A very, very important nerve and very likely to be asked again in the exam. In the posterior cranial fossa, we are not able to identify the foramen. So at least we can see the nerves in the tuft, guys. What I'm looking at here, it is the internal acoustic meatus. This is the jugular foramen area, और उसके नीचे hypoglossal canal. This तो obviously is a foramen magnum only. This is a foramen magnum. You can see vertebral artery over there. This is internal acoustic meatus. This is a jugular foramen area, and those are the hypoglossal nerve rootlets, small here. So if this is the internal acoustic meatus, 7th and 8th nerve will come out from there, right? If this is a, jugular foramen area, 9th, 10th, 11th nerve will come out from there. And if that is a hypoglossal nerve area, then obviously hypoglossal nerve will come out from there. So you can identify the nerve by the sequence also. Tuft of nerve, tuft of nerve, tuft of nerve. Internal acoustic meatus wali nerve, that is 7th and 8th, 9th and 11th, that is, and then we have the 12th nerve, the hypoglossal rootlets are present there. So if you're looking for the nerve to identify in the posterior cranial fossa, you just have to go in the sequence. ऊपर से नीचे जाना है, internal acoustic, jugular foramen, hypoglossal canal, and based on that you can identify the nerve. Because yeah, it becomes a little challenging, because if the cranial fossa is given and the durameter is present on it, and foramen तो दिख ही नहीं रहा, and you still have to identify the nerve in that here. Till date, they've asked this question twice in the exam. Both the time INI-CT and both the time it was a sixth nerve they have asked here, which is easy to identify, to be honest, guys. If you know that the only nerve present on the clivus is sixth nerve, then it is not difficult. Another thing which is very, very repeatedly asked in the exam, and I'm sure everyone will agree with me on this, and that is the styrion. The styrion, guys, the four bones which are contributing to styrion, as you can see, it's a frontal bone. You can see that's this H-shaped suture over there is a styrion. The frontal bone is contributing to it. The parietal bone is contributing to it. This is the temporal bone, and remember, it's a squamous part of temporal bone, and it's the greater wing of the sphenoid. यहाँ पर गलती करते हैं लोग. It's the greater wing of the sphenoid which is forming the styrion, and it's the squamous part of temporal bone, not petrous part. And this is the greater wing of the sphenoid. The four bones which are meeting at this point, that is called as a styrion. That point is called as a styrion. Oh, this circle started now. Now, what makes this styrion so important, guys? Now, I've kind of overlapped these two pictures together. I've just overlapped the brain on the skull image to see. And this is approximately the area of the styrion here. What is in relation, guys? Middle meningeal artery, and especially the anterior division of middle meningeal artery, is passing deep to the styrion. It's the anterior division of middle meningeal artery, and that is not the only thing. Anterior division of middle meningeal artery, number one. Then middle cerebral, because see, this point here is a Sylvian point. That's a Sylvian point. So middle cerebral artery will enter through it here. Broca's area will be present somewhere. Area number 44, 45. Broca's area is present here in this area only. On the left side, the Broca's area obviously on the left side that is present over there. Sylvian point, as I said. And to tell you, lesser wing of the sphenoid is also there, but on the inside. Lesser wing is in the relation, guys. Lesser wing is in the relation. That is not. Okay. So Broca's area, insular cortex. If I open this sulcus here, then obviously what is the hidden area inside? That is insula. So all these structures are present deep to the pterion. Obviously, their question generally is about the middle meningeal artery because that is involved in the extradural hemorrhage. But the structures, when you go deep to the pterion, you will find the middle meningeal artery, you will find the Broca's area on the left side, you will find the Sylvian point, you will find the insula. So all these structures are present deep to the pterion here, deep to the pterion. And it goes without saying that there's a very fragile area of the skull bone, the thin area of the lateral side here, and that's why any injury at the side of this can lead to the this is too violent actually. So rupture of the anterior division of middle meningeal artery, and that can cause the extradural hemorrhage here. The fracture of this region here, this bone is easily fractured here, and the middle meningeal artery rupture can lead to the EDH, the extradural hemorrhage. Stop. No worries. There will be no more delays in the PG examination. So this was a quick recap on this head and neck part here. Chalo, पहले जल्दी से मुझे review दो. If you are able to follow the major part here, then I will start with the neuroanatomy. 30 seconds break. Okay. Chalo, all going good? Some people brain is bursting, it seems. So better if that is the case. Chalo sir. Thank you so much. The break is over. Let's get back to the topic. The neuroanatomy. In the neuroanatomy, the first topic that I'm discussing with you directly is a Brown-Sequard syndrome. Because in the Brown-Sequard syndrome, we understand about that what the tracts are doing. Guys, and before I put the picture there, in the spinal cord, the three major ascending tract, the dorsal column tract, the spinothalamic tract, and spinocerebellar tract, and descending tract is a pyramidal tract. I'll tell you in a very simple format here. Again, examiner is like, they can ask you about the tract also, but it's usually about the lesions and injuries here. There is only one tract which is going to decussate at the level of spinal cord, and that is the spinothalamic tract. Spinothalamic tract, ascending tract, I'm talking about ascending tract. In the ascending tract, the spinothalamic tract is decussate at the level of spinal cord. Rest of the tract, they are not decussating or they are decussating above the spinal cord. So in the spinal cord lesion, like in Brown-Sequard syndrome, everything will be lost on the ipsilateral side except the things which are carried by the spinothalamic tract, and that is pain, temperature, crude touch and pressure. Pain, temperature, crude touch and pressure is lost on the contralateral side. बाकी सब कुछ ipsilateral side से जाएगा. Whether it is conscious proprioception, vibration, stereognosis, unconscious proprioception, okay, all will be lost on what side? On the ipsilateral side, except the things which are carried by the spinothalamic tract. Now, look, let me just go nice and easy in this. What you're looking at, right? Let me just put this picture first. See, this is a picture which is telling you about that what is happening in the Brown-Sequard syndrome. I'm sure everyone knows that in the Brown-Sequard syndrome, there is a hemi-involvement of spinal cord. Half of the spinal cord is involved. That means all the tracts at one level will be gone. Now, guys, let us say if this is a spinal cord here, and there is an involvement at this level where my two fingers are pointing that this is the injured on the side, one side, and this is involved. Now, at the level of lesion, everything will be gone. At the level of lesion, I'm not talking about below the 11 or above the, at the level of lesion, everything will be gone ipsilaterally. Whether pain, even the pain and temperature, touch, pressure, conscious, unconscious, everything will be lost on the ipsilateral side at the level of lesion. Ipsilateral loss of all sensory modalities at the level of lesion. जिस level पे lesion है, if the nerve comes inside, that nerve is not able to relay the sensation. It doesn't matter it is decussating, not decussating, decussating here, decussating up there, doesn't matter. The level of the lesion, everything will be lost at the level of the lesion here. Ipsilateral loss of all sensory modalities at the level of the lesion, वो तो होना ही है. Ipsilateral spastic paralysis below the level, I'll explain that to you. Ipsilateral loss of vibration and position senses, and contralateral loss of pain and temperature below the, I'll tell you guys. See, spinothalamic tract is the one which is carrying the pain, temperature, crude touch and pressure. And when it carries pain, temperature, crude touch and pressure, in the spinal cord only they will decussate and they will go above. So if there is an injury at the level of spinal cord, if the injury is left side, so it is a mainly dominant loss is present on the left side here. Because the tract is decussating at the level of spinal cord. Agar it tract upar decussate karta in the brainstem, then the loss would have been on the same side only. Dorsal column tract runs on the same side. Cerebellar tracts ultimately come to the same side, so that the effect is on the same side only. Spinothalamic tracts are carrying the sensation and they decussate at the level of spinal cord. That's why pain, temperature, crude touch and pressure. They've only mentioned that pain, the loss of pain and temperature. It's not only pain and temperature, pain, temperature, crude touch and pressure will be lost from the contralateral side. Everything else is on the same side. Even paralysis is also on the same side only. The pyramidal tract will decussate and will go downward and supply. Now, once the pyramidal tract decussates in the medulla oblongata, it runs downward in the spinal cord. If the injury is toward the right side, the right side muscle will be gone. The tract is already decussated here. So, if the injury is now on the right side involvement will be there. But to understand the difference between the spastic paralysis and these, the flaccid paralysis, let's take an example, guys. Let's say this is a spinal cord here. Now, this is a corticospinal tract or pyramidal tract coming below to the spinal cord. Some fiber here, some fiber here. And these are all what? They are all upper motor neuron. Obviously, they are coming from the cortex. That is a spine. This is a corticospinal tract or pyramidal tract. That is the upper motor neuron. Lower motor neurons will come out from the spinal cord. That's a lower motor neuron. That's a lower. These are all lower motor neurons which are coming out from the spinal cord. If there is a Brown-Sequard syndrome, let's say at this level, guys, look at this point here where I'm, if this is the site for the Brown-Sequard syndrome, now what will happen? At the level of Brown-Sequard syndrome, you can see the cell body of this lower motor neuron is affected. And that is why at the level of lesion, it's more like a lower motor neuron lesion. That's why there is a ipsilateral flaccid paralysis at the level of lesion. At the level of lesion, there is a flaccid paralysis because lower motor neuron injured ho gaya. But rest of the lower motor neurons are working. You can see their cell body, you can see the rest of the axon, everything is fine. Lower motor neurons are fine, but their upper motor neuron is injured here. And that's why below the level of lesion, there is a spastic paralysis because lower motor neurons is working. They will keep on stimulating the muscle and the muscle will undergo the spasm. So at the level of lesion, there is a flaccid paralysis because it's a lower motor neuron type of lesion, and below the level of lesion, all the neurons are working. The lower motor neurons are working, but upper motor neurons, they have to pass through this Brown-Sequard syndrome area. So obviously they are not working here. So there is a ipsilateral flaccid paralysis at the level of lesion, but there is a ipsilateral spastic paralysis below the level of lesion. Overall, if you look at the entire Brown-Sequard syndrome in the shortest format, what I would say, that everything is on the same side. First of all, सब कुछ same side से जाएगा. Everything is lost from the same side except for pain, temperature, crude touch and pressure. First thing, except for pain, temperature, crude touch and pressure, which is gone from the contralateral side. Secondly, paralysis is also the same side, but at the level of the Brown-Sequard syndrome, it's a flaccid paralysis, but below the level of the lesion, it is a spastic paralysis, hai ipsilaterally. That's Brown-Sequard syndrome in short. If you remember this, guys, you will not get a question wrong on this here. That there is a contralateral loss of pain, temperature, crude touch and pressure, and ipsilateral loss of everything sensory or motor. But at the level of lesion, flaccid, below the level of lesion, spastic. That's it. Okay, now when you look at the brainstem, the ventral aspect of the brainstem and the dorsal aspect of brainstem. See, this question can never get old, guys. The ventral and dorsal aspect of brainstem, and because ventral aspect of the brainstem, it's all about how cranial nerves are coming out from there, and dorsal aspect of brainstem is about the fourth ventricle. So this has to be the very, very important. I mean, you, no matter a question kitni baar pucha ho, you cannot leave this. Now, when you look at the ventral aspect of the brainstem, guys, what you're looking at here, this portion here is a cerebral peduncle, this portion here is the pons, and that is a medulla oblongata, right? So in the midbrain, in the midbrain, that is cerebral peduncle over there. That marked area is a cerebral peduncle, also called as a crus cerebri. And between the two crus cerebri or cerebral peduncle, that fossa over there is called as the interpeduncular fossa, guys. That area on the inside where mammillary bodies are present, that is called as the interpeduncular fossa. You will see the nerve coming out from the interpeduncular fossa, that is the third nerve. The only nerve coming out from the interpeduncular fossa is the third nerve. The only nerve coming from the dorsal aspect of the brainstem, it is a fourth nerve. Right? Third nerve and fourth nerve, and you will see both the nerves are winding around the cerebral peduncle, guys. So, अंदर से आ रहा है वो third nerve है, the nerve coming from the dorsal aspect of brainstem, that is a fourth nerve. Pons, there are so many nuclei present inside the pons, but only one major thick nerve comes out of the ventral aspect of the pons, and that is the fifth nerve or the trigeminal nerve. The only nerve. Although you can see two parts of the trigeminal nerve, the thicker part is the sensory part and thinner part is the motor part here. Because trigeminal nerve mainly is the sensory nerve. So thicker part is sensory, thinner part is motor, but head trigeminal nerve is, guys. The only nerve emerging from the ventral aspect of the pons is the trigeminal nerve. Then from pontomedullary junction, we have sixth nerve, medial most. Then we got a seventh nerve. Again, you're looking at two parts of seventh nerve. It is marked on the other side. Two parts of seventh nerve. This time, thicker part is motor and thinner is sensory. Thicker part of the facial nerve is motor, guys, because facial nerve is mainly a motor nerve, and thinner part is sensory because thinner part of this facial, you know what is the thinner part called? It is called as a nervus intermedius. That's a main motor branch of facial nerve, and this is called as a nervus intermedius. And the function of nervus intermedius is nervus intermedius carries the parasympathetic fibers of facial nerve, and it also carries the sensory fibers of the facial nerve here. Sensory fibers and parasympathetic comes from nervus intermedius, and the main facial nerve is a facial nerve. This one, kul milake, both are facial nerve only. And then the more laterally placed nerve is the eighth nerve. So 6th, 7th and 8th. 6th, 7th and 8th nerve, the three nerves coming out from what junction? Pontomedullary junction. When you look at the medulla oblongata, in the ventral aspect of medulla oblongata, guys, this elevation, this rounded egg-like elevation that you see, that is the olive. And more medial to the olive, that is a pyramid. That is a pyramid and olive you're looking at. The three nerves that you see coming from the dorsal side of the olive, or the lateral to the olive, that is the 9th nerve, 10th nerve and 11th nerve. And let me clarify this thing to you, guys. This is the 9th nerve. This is the 10th and cranial accessory nerve together. Vago accessory complex. This is the 10th nerve and accessory nerve together. Cranial accessory nerve together. And this nerve, where I've written 11th over there, it's actually a spinal accessory nerve. You can see it's coming from the spinal cord. It's a spinal accessory nerve. That is the 11th nerve here. So when you say 9th, 10th and 11th nerve, when you're looking at the 10th nerve, you're not only looking at the 10th nerve, you're looking at the cranial accessory nerve also in it. And then 11th nerve, which you're talking about, that is a spinal accessory nerve. And the only nerve that you see coming out between the pyramid and olive, that is the hypoglossal nerve. That is a hypoglossal nerve. So that's the ventral aspect of the brainstem, guys. Third nerve from the interpeduncular fossa. Fourth nerve is coming from dorsal aspect of brainstem. Fifth is the only nerve present on the ventral aspect of the pons. Sixth, seventh and eighth nerve, they are at the pontomedullary junction. 9, 10, 11 are lateral to olive. And 12th nerve is the only nerve between the pyramid and the olive. Between the pyramid and the olive. Let me take you to the dorsal aspect of the brainstem. Now that's a real-time picture of the dorsal aspect of brainstem. When you see the dorsal aspect of brainstem, guys, this area here is a midbrain area. That's the one you see above. That is a midbrain area over there. I feel so helpless when I just move out of the frame. That is the midbrain area. And these are all peduncles, guys, cerebellar peduncle. We have a superior cerebellar peduncle. From below, we have an inferior cerebellar peduncle. And pons will have a middle peduncle. The three peduncles are there. And you can already see the rhombus shape inside. That is a fourth ventricle. So when you're looking at the dorsal aspect of brainstem, you're talking about the fourth ventricle here. Those four rounded structures over there are the superior colliculus and inferior colliculus. We have two superior colliculus, we got two inferior colliculus, and the superior and the inferior colliculus together, they are called as a corpora quadrigemina, guys. Four gem-like structure, they're called as a corpora quadrigemina. The four gem-like structure, this is called as a corpora quadrigemina. And the one nerve that you see which is coming out below the inferior colliculus, that is the fourth nerve. The only nerve emerging from the dorsal aspect of brainstem. Look at that. You can see it's a thin nerve over there coming out from there. Now, in the dorsal aspect of the brainstem, the question which is asked most of the time, it is on this elevation which is present in the floor of the fourth ventricle, and that is called as a facial colliculus. The other things are also there, but facial colliculus is their go-to question in this, guys. Facial colliculus is the one which is the main structure present over there. Facial colliculus, I'll tell you about it. Then just below the facial colliculus, we have a triangle called as a hypoglossal triangle. There is a hypoglossal triangle or trigone. And further below in inferior, there is a triangle called as a vagal triangle because vagal nucleus is present there. So we got a facial colliculus, the hypoglossal trigone and vagal triangle or triangle you can call them, and all these are present more or less in the same line only. In the real time picture, it's difficult to differentiate them very clearly. Agar ye atlas image hota, hand drawn picture hota, it will be more easier. And the triangle which is present more toward the outside is called as a vestibular triangle, where vestibular nuclei are present there, vestibular area you can call it here. So guys, if the question is asked that how many nuclei are present in the floor of fourth ventricle, then please don't get confused with the facial colliculus. Facial colliculus is not because of the facial nucleus, it is because of the facial nerve winding around what? Abducens nucleus. Like, look at this picture here. You can see facial nerve is winding like this, going toward the dorsal side, and then it is coming out forward. It's the abducens nucleus forming the internal genu. So facial colliculus is obviously having facial nerve deep to it, but obviously which nucleus? Sixth nucleus. So what nuclei are present in the floor of fourth ventricle? You will say it is 6, 8, 10 and 12. Facial colliculus is because of 6, we have a 6 nucleus deep to it, 8 vestibular, triangle, there is the vagal is 10 obviously, and 12 is hypoglossal here. So 6, 8, 10 and 12. 6, 8, 10 and 12 here. And yes, that is the very next thing I was talking about, guys. Abducens nucleus surrounded by the lower motor neuron lesion of facial, lower motor neuron of facial nerve. It's when I say facial colliculus, the nucleus is abducens there, but the nerve which is surrounding it is a facial nerve. It's a lower motor neurons of the facial nerve which are surrounding it here. So every time we say there is an injury to the facial colliculus, तो सबसे पहले nerve जाएगा. The nerve will get injured first. Nucleus is like this and nerve is surrounding it here. So any injury to the facial colliculus, the structure which is involved or likely to get injured, first is the facial nerve, then there are chances of nucleus here. So always go for the muscles of facial expression involvement. Lateral rectus is not going with the first answer, guys. Injury to facial colliculus, your preferred answer is a lower motor neuron lesion of facial nerve. Lower motor neuron facial nerve, and which will cause what? Ipsilateral facial paralysis. Which will cause ipsilateral facial paralysis. Which will cause ipsilateral facial paralysis. So that is about the dorsal aspect of the brainstem, and you're looking at the rhomboid fossa in this. Okay. Moving on. Now coming to the ventral and dorsal aspect of the brain. So guys, let's talk about the sections of the brain. Now from the core anatomy point of view, identifying the sections of the brain according to me is the most important thing, is the single most important thing in the neuroanatomy that you need to do. Sagittal section, transverse section, coronal section. Sir, sections को नहीं छोड़ना है. And I'm not saying that you may get a question on this. I'm telling you, you will get a question on this. There will be one question, at least minimum one question on any section of the brain. Could be transverse, could be sagittal, and they keep on asking these questions over and again. If you're leaving the sections of the brain, that's a crime. Don't do that. First, the sagittal section, guys. If I look at the sagittal section, this will tell you about the third ventricle boundary. Let's get oriented to this picture first. If anyone read about this, then fine. If not, look at this. Now, what you see in this picture, guys, this here is a corpus callosum that you see above. That my hand is right now on the splenium of corpus callosum. Just below the corpus callosum, you can see that white matter bundle which is running over there. That is a fornix. And then below the fornix, whatever is this green highlighted area that you're looking at, this here is the third ventricle. That all green like highlighted area here is a third ventricle. If this is a third ventricle, let me just put that. If this is a third ventricle, now what are the boundaries of the third ventricle that you see? Above is the body of fornix, that white structure over there is the body of fornix, and just below that is the choroid plexus. Let me use these arrows only. So here is the body of the fornix, guys, and just below that you can see choroid plexus, and body of fornix and choroid plexus are forming the roof of the third ventricle. Posteriorly, this gland over there where I'm pointing at right now, I hope all of you can see that. I'm pointing at right now, this is a pineal gland. And pineal gland is having a superior lamina and inferior lamina. Superior lamina of the pineal gland is having a commissure called as a habenular commissure, और नीचे वाले lamina के अंदर we have a posterior commissure. There is a habenular commissure there. Then we have a pineal gland. Then we have this commissure called as posterior commissure, and further you can clearly see that is an aqueduct of Sylvis coming toward the fourth ventricle. That is an aqueduct. So habenular commissure, pineal gland, posterior commissure and aqueduct of Sylvis, they are all forming the posterior wall of the third ventricle. Posterior wall of third ventricle. No, yaar, I don't want to use that pointer. I don't like using these mouse pointer. I can use the mouse pointer there, but I like to be a little more animated and go and show the structures here. That's why I feel, let's say, ये तो मुझे पता pointer use कर सकते हैं यार. Okay, let me put this pointer aside only. Okay, when you look at the anterior wall is by the commissure called as the anterior commissure. Look at that rounded structure over there is the anterior commissure, and just below the anterior commissure there is this lamina terminalis. Lamina terminalis is the cranial most end of the neural tube. When we saw that today when we talked about the neural tube, guys, neural tube ka jab anterior end, the anterior end of the neural tube closes, that forms the lamina terminalis. So it is a representation of the cranial most end of the neural tube, that is the lamina terminalis, and both lamina terminalis and anterior commissure, they form the anterior wall. And then comes the floor. The floor of the interpeduncular, the floor of this third ventricle, if I see the floor of this third ventricle from this side, it is actually interpeduncular fossa. If I see it from this side, then it is the floor of third ventricle. So guys, if I see from here, this is the optic chiasma, this is infundibulum of pituitary, that is mammillary body, and that is posterior perforating substance, and all of these are present in the boundary or in the content of interpeduncular fossa only. But when you see it from the above, in that sequence, the optic chiasma, the infundibulum of pituitary, the mammillary body, which is a recent question, mammillary body projects into which thalamic nuclei? Anterior thalamic nuclei, and then posterior perforating substance, they are all present in the floor. Identification is the key, sir. Identification. In this section, you are looking at the boundaries of the third ventricle. As you can see, roof is by the body of fornix and choroid plexus. Posterior wall is by these four structures here. You can see anterior wall is by lamina terminalis, anterior commissure, and floor, the most important floor, is having optic chiasma, infundibulum, mammillary body, which is a recent question. Mammillary body projects into the anterior thalamic nuclei. But what is the lateral wall? I can see anterior wall, posterior wall, roof, and the floor. What about the lateral wall, guys? Lateral wall, look at this rounded structure over there is thalamus only. And this one is the hypothalamus. This area is a hypothalamus here. So thalamus and hypothalamus is forming the lateral wall of third ventricle. So that way we have covered this transverse section also, sagittal section also, and we've covered the boundaries of the third ventricle as well. If I show this in the radiological picture, and because this was an INI-CT question asked, guys, they showed the picture something like that, and the two arrows were placed. One arrow is placed somewhere here, which is behind the inferior colliculus. Like, I hope you can make out that's a midbrain, that is pons, that is medulla oblongata, this is fourth ventricle. So there is one arrow which is just behind the, what do you say, inferior colliculus, and one arrow, if I place, it is in the floor of fourth ventricle. What are the nerves present here? The only nerve which is emerging from the dorsal aspect of brainstem is the fourth nerve. No doubt about that. Fourth nerve will come out in the longest intracranial course. And if the arrow is placed in the floor of fourth ventricle, then we know facial colliculus. We just saw facial colliculus is like here. So facial nerve winds around the abducens nucleus and comes out. So it's a facial nerve. I'm not saying nucleus. Facial nerve is present here. So if ever they ask you the question and they put the arrow behind the brainstem, they either will put the arrow below the inferior colliculus where the fourth nerve is coming out from, or they will place the arrow in the floor of fourth ventricle where seventh nerve is coming out from. यही दो आंसर हो सकते हैं. Coronal section. The coronal section of the brain where we will be appreciating about the lateral ventricle. In the sagittal section, we talked about what? We talked about the third ventricle. We already saw fourth ventricle, that is in the dorsal aspect of brainstem. Now in the coronal section, we'll understand about the lateral ventricle, guys. Now first of all, when you look at this section, here is the corpus callosum. Just for the orientation, this is corpus callosum. These two cavities over there are the lateral ventricle, which are separated from each other by a thin septum called a septum pellucidum. And this is a third ventricle. ये दो lateral ventricle है, and then we have a third ventricle below here. And we already know the third ventricle lateral boundaries were thalamus only. That means this is thalamus, this also is thalamus. Corpus callosum is forming the roof of the lateral ventricle. If I talk about the lateral ventricle point of view, that is corpus callosum forming the roof. If I just look at the white matter first, guys, that is corpus callosum. And look at this white matter bundle. I hope you can make out this white matter bundle running vertically upward. This is internal capsule. Look at this one. This is the internal capsule over there. And the same internal capsule, once it reaches the level of corpus callosum, it radiates everywhere in the cortex, and that becomes corona radiata. So internal capsule till the level of the corpus callosum, it's compact. And by the time it reaches the level of corpus callosum, then it radiates everywhere, and that becomes corona radiata. So the corpus callosum is the junction of the internal capsule and corona radiata. The hidden cortex, which was, if I'm not wrong, the very first image-based question asked in the INI-CT exam, they gave this coronal section and they asked about the insula, guys. Hidden cortex. That over there is the insula here. This is the insula. Let me show on this side here. This is the hidden cortex. Unless I go into the sulcus from outside, unless I open this sulcus from outside, मैं इस एरिया तक पहुंच ही नहीं सकता. So this is a hidden area of the brain, and that is called as the insula or insular cortex. That is insula or insular cortex. And what you see between the insular internal capsule, the lentiform nucleus is present there. The lentiform nucleus is kind of sandwiched between the lentiform nucleus is between the insula and the internal capsule. Now, let's focus back to the lateral ventricle. Now, we say lateral ventricle, guys, roof is by corpus callosum. The medial wall of the lateral ventricle is by this one thing only, and that is a thin septum called a septum pellucidum. It's a pellucid septum. It's a translucent septum. We call it septum pellucidum. And then from here to here, everything is present in the floor. There is no, see, there was no third nerve in the third ventricle, and there is no lateral wall in lateral ventricle. नाम lateral ventricle, but lateral wall नहीं है. Life is not fair, guys. Roof is there, medial wall is there, floor is there, but there is no lateral wall in this lateral ventricle. We have what? We have everything is floor. Starting from here, this rounded nucleus here is a body of caudate nucleus, number one. Then we have what? Thalamus, number two. And then whatever is present in the roof of the third ventricle, that is fornix and choroid plexus. Look at that, guys. That is a fornix and choroid plexus. They are present in the floor. Whatever is present in the roof of the third ventricle is present in the floor of lateral ventricle. With choroid plexus and fornix, we saw it is in the roof of third ventricle, so they are in the floor of the lateral ventricle. That is the floor of the lateral ventricle. Because this presentation is reaching you guys immediately after the moment I say the last word, and from the phone I'll post that thing in your group here. Okay, so that will reach you. This presentation will reach you. So don't worry about that. It's not that you will be getting the presentation tomorrow or somewhere. I know your time is precious. Tomorrow you have other subject to go, and I'm sure many of you would want to just read it tonight only. This and just want to get rid of this thing here. So वो आपको मिल जाने वाला. Like it's like my fingers are on the button only. The moment we end the class, and I'll not take even a minute to send the entire copy to you. I hope you understood these two sections, guys. The sagittal section told you about the boundaries of third ventricle, and the coronal section, apart from insula and internal capsule and everything, it tells you specially about the boundaries of the lateral ventricle. Roof is by corpus callosum for the lateral ventricle, medial wall is septum pellucidum, and everything that I've highlighted here, that is present in the floor. Now, the fornix, guys, in the previous section, you can see fornix was still looking better, but you cannot see the entire fornix. There is no possible way to see the entire fornix in any normal section of the brain. Fornix is a white matter bundle which is running in such a way that ऐसा कोई section ही नहीं है जिसमें आपको पूरा fornix दिखाई दे. You're not able to see the entire fornix in any possible way. Like right now, it looks like a just like a something white over there, just some bundle over there. But actually, there are two fornix. It's like fornix will start like this. It will go. These are two fornix. Like my two fingers are projecting the fornix only. They will come very close to each other, and that's what you're looking at right now over there. And then they go downward and they terminate into the mammillary body. Let me show you a picture where we can try to appreciate that, because there was a question asked on the fornix twice. This blue colored bundle over there is a dissection done for the fornix only, guys. Just for your understanding first, this is once again corpus callosum. This is a lateral ventricle that you can see, obviously divided by septum pellucidum, which is not there. And then we have fornix. So if you see the fornix fiber, they're starting from where? Hippocampus. Hippocampus is the origin of the fornix, guys. That is the origin of the fornix. And termination of the fornix is ultimately into the interpedunclar fossa. Into what body? Into the mammillary body here. और सर ये क्वेश्चन एक से ज्यादा बार पूछा हुआ है, that fornix originates in the hippocampus and terminates to mammillary body. Be careful about that. They have only asked this question till now, that where they originates. Hippocampus. Maybe next time they will ask you where they're terminating, and that is mammillary body. Correct. Coming to the next section, and that is the transverse section, guys. Let's talk about the transverse section in this. Okay, the transverse section, guys, what it shows you, we saw the sagittal, we saw the coronal, and now coming to the transverse section. No, beta, amygdala is joined by the anterior commissure. Dumpy. Amygdala is connected by the anterior commissure. You are mistaken there. Look, this is the transverse section, and I'm going to show you something very nice here. I'm sure that you will like that. This is the transverse section, guys. Now, what you see, like obviously this will be the area where the corpus callosum is present. Corpus callosum obviously is present here. Fibers of corpus callosum are running from one cerebrum to another. That is also there. This is the anterior most part of the corpus callosum, that is genu part here, and that is the posterior most part of the corpus, that is the splenium. The fibers from the genu of the corpus callosum, they are running forward and they're connecting the frontal lobe of one side to the frontal lobe of the other side, guys. And those fibers are called as a forceps minor fiber. These fibers which are coming from the splenium of the corpus callosum, they are called as the forceps major fiber. But these forceps major fibers are present medial to the posterior horn. आपको transverse section में you will be able to see the anterior horn. Look at this horn over there. That's an anterior horn of lateral ventricle, and that is a posterior horn of lateral ventricle. The horns are visible, anterior horn and posterior horn. So anterior commissure is medial to the anterior horn, and posterior commissure is medial to the posterior horn. They are medial to the respective horns, guys. Anterior commissure. Now I'll use your idea. Just one second. Yeah, what I'm saying is that this is the anterior horn and this is the posterior horn over there. So this point, this where I'm pointing at right now, this is the posterior. This is the posterior. What do you say? The forceps major here, and these are the forceps minor fiber. If you see, this forceps major fiber is such a thick white matter bundle that it is projecting into the medial wall of the posterior horn and producing this elevation called as the bulb of the posterior horn. Okay, that is forceps minor, this is forceps major, and because of forceps major, this elevation over there is called as a bulb of the posterior horn. That is called as a bulb of the posterior horn. More lateral to the posterior horn, guys, that white matter bundle that you're looking at over there, this is called as a tapetum fibers. That is again coming from the splenium and the posterior part of the corpus callosum, and they're also running backward only. But remember, they're covering the posterior horn. Posterior horn ki medial side mein hai to forceps major, and on the lateral side it is a tapetum bundle. Tapetum. And in this section, you can also see the internal capsule. Look at this. That's an internal capsule over there. This is the internal capsule to be seen in the transverse section, which is surrounded by these three important nuclei. That is a caudate nucleus. This time it's the head of the caudate nucleus, the thalamus, and lateral side mein it is a lentiform nucleus. That is a lentiform nucleus. And another, what do you say, view of the insula. That's an insular cortex, guys. The cortex which is present on the lateral side. That is the insula. So these are the things that you should be able to identify in the Siddharth, beta fornix. Yeah, fornix are all three types of fiber, but association fiber, commissural fiber, and if you have tried the association fiber is the best example, commissural fiber is the second best, and it can also be counted in the projection fiber. It is all three type, but you're right, association fiber and commissural fiber is a better answer for the fornix if you have to choose two out of the three. Okay, guys, I hope you understood this section. Now, look at this, and this is something which kind of I really feel happy showing this picture to everyone. Now, this is an MRI that you're looking at, the brain MRI, guys, the axial section. Now, what I did is, and already my review of the class is being shared. Let me mark excellent myself. Koi aur kare na kare. Okay, now look, guys, this is the transverse section here. No, she deleted it. There's a transverse section. Bhavana, that is okay. Chalta hai, that's okay. So, guys, the thing about this section is that MRI, the brain MRI axial section is. I took the picture which I just showed you guys. This one. मुझे बहुत मजा आया करने में ये वाला ना. I took this picture and I took this MRI and I just tried to superimpose them. And I really felt good because it superimposed so perfectly. Now, it will look like that somebody put the color in the MRI only. Guys, have a look at this. And I want to just enjoy this thing. Look at this. Wow, this is so satisfying, isn't it? It looks like a perfect match only. So it's just that this MRI image is given and we overlapped this with this cadaveric, this picture here, and it matched perfectly. And let me put all the labelings here. Just let me give you just a couple of seconds. Just look at this, guys. Just understand, on one side we have a cadaveric picture and one side we have MRI, and you can just compare the two. Whatever you can see on the one side cadaveric, the same exact thing that you can see on the other side in the MRI view also. Magic, okay. Magic kuch nahi hua. It's a good superimpose only. Yeah, I told that in the class. I love that actually. That just this. In the class with the picture which I've showed you, it was not an animation. In the class which I've showed you the picture which is overlapped already here. I kind of just showed you it, overlapping it. I fade in किया मैंने इसको इसके ऊपर, तो I find it very satisfying. Okay, chalo guys, this is the transfer section. The same thing which we saw in this previous image. All I'm saying is that just do not leave these three sections question आना है sir. You will get a question from either from sagittal, from transverse, from coronal section. You just cannot leave any of these three sections here. Moving on to the cerebellum. Chalo. Now, I mean, moving on to the cerebellum means in Bhatia's only, but moving on to the cerebellar cortex. So cerebellum, guys, cerebellar cortex, there are three layers in the cerebellar cortex. As you can see, there is a molecular layer, there is a Purkinje layer, and there is a granular layer. In the cerebellar cortex, in the gray matter of the cerebellum, we got three layers there. Molecular layer, Purkinje layer, and granular layer. I'm doing full-on masti in this class. Generally I don't do that much in the class. You must be knowing that. So, guys, in the molecular layer, we have two types of cell. What are those? We got a basket cells and stellate cells are there. Then we have Purkinje layer. We got a Purkinje layer. Obviously, we got Purkinje cells. The name says Purkinje layer, so we have a Purkinje cells. And guys, granular layer, we have two types of cells which are called as the granule cells and Golgi cells. When you read these slides, just go through that. The same color code is shown here. Not the exact way the cell will look like here, but that's a representation, a schematic representation. So in the three layers of the cortex, we got five cells over there. Basket cells, sealed cell, these are supporting cells only. Purkinje is the main cell. Our discussion basically lies around the Purkinje cell only. And then we have a granule cells and the Golgi cells which are present in the granular layer. As a matter of fact, whatever is present in the granular layer, उन सबकी spelling G से start होती है. Golgi cells, granule cells, glomeruli, G for ground floor, सबसे नीचे वाली layer भी यही है. So granular layer is the one which is having a granule cells and Golgi cells. Okay, guys, 3, 1 and 2 these. Now out of these 5 types of cell, now imagine out of the 5 types of cell, 4 of them are inhibitory. Granule cell is the only excitatory cell. So it is like inhibitory. Like it is flooded with the inhibitory cells, guys. Like it's so many negative cells are there. Like this cerebellar cortex, yeah, it's so negative. It's all negative. All are inhibitory cells there inside. Only excitatory cell is a granule cell in this. Only excitatory cell is a granule cell, and that is why cerebellar cortex is the largest collection of inhibitory neuron in entire central nervous system. Nowhere in the central nervous system we have these many inhibitory neuron, except for this granule cells which are excitatory. Rest all of them are inhibitory only. Chali sir. So that was about the cells inside. Now let's talk a little beyond that. Now, Purkinje cells are the one which are coming out. We'll talk about the Purkinje cell separately also after this. Now guys, what about the afferent fibers? Now can you see this orange color and green colored fiber? These are fibers which are coming inside. If you look at the orange fibers here, they are the one which are entering the cerebellar cortex and reaching the topmost layer. And when you're looking at the green colors layer, the green color fibers are the one which are reaching till the granular layer only. So we have two types of fibers. We got a climbing fibers and we got mossy fibers. Climbing fibers, when you say climbing fibers, because of their climbing capability, these fibers can climb to the topmost layer and they can directly make a synapse with the Purkinje cell. And mossy fiber, नाम सुनने में लगता है mossy ji, old body see mossy ji cannot go beyond the granular layer, ground floor. So mossy fiber will only reach the granular layer only. You can see the green color fiber, they're reaching the granular layer. And that also explains you that why granule cells are excitatory. Because mossy fibers will reach only to the granular layer. It's the granule cell which will form the connecting link between the mossy fiber and then the Purkinje cell. And that's why they're excitatory. All other cells are inhibitory, but they are excitatory because they are the connecting link between the mossy fiber and the Purkinje cell. So climbing fibers are the one which directly climb to the topmost layer, and mossy fibers are the one which will use the granule cell to make a synaptic contact with the Purkinje cell. Okay. Which fibers are climbing? Which are mossy? That is also very easy, guys. All fibers are mossy except olivocerebellar and paraolivocellular. That's it. Any tract coming from olivary nucleus or para-olivary, जहां आपको tract के अंदर olivary और para-olivary लिखा दिख जाए, olivocerebellar, para-olivocerebellar, it is coming from inferior olivary nucleus, superior olivary nucleus, they're going toward the cerebellum. Olivary or para-olivary nucleus, a tract, whatever they're coming, they're all climbing fiber, and rest everything is mossy. Rest all are mossy. Whatever tract, guys, coming into the cerebellum, dorsal spinocerebellar, ventral spinocerebellar, cuneo-cerebellar, vestibulocerebellar, reticulocerebellar, dash cerebellar, jo bhi ho, doesn't matter. If it is coming into the cerebellum, and if it is not olivo or para-olivo, they're all climbing fibers. Yes, my dear, you get the PDF with all the memes only, but obviously memes will not be animated in that. Chalo. Now, this is a very low magnification section of the cerebellar cortex only, the arbor vitae, guys. When you look at the cerebellar cortex, let me enlarge it further here. That's how it is going to look like. You can see the three layers over there. You can see molecular layer. The junctional layer is a Purkinje layer. Purkinje cell will be at the junction. And then obviously the granule can be seen inside. That's a granular layer. To see the Purkinje cell, we have to like enlarge it even further. And if I enlarge it even further, now I can see the Purkinje cells here. Histologically, if they ask you a question, they can ask you the question on the granule cells only, or this Purkinje cells only, because that's the only cell you can differentiate. बाकी तो सर differentiate ही नहीं हो पाएंगे. How will you ask the question on them here? So this is the Purkinje cell, guys. That is a Purkinje layer. The Purkinje cells are there. Purkinje cells are the only cells which are forming the efferent from the cortex. Rest all the cells are having internal connections. All these granules and Golgis and your baskets and stellates and all these cells are having internal connections only. Purkinje cell is the only cell which will send the axon out of the cortex. So they are the only efferent from the cortex. But be please very careful with that. It's the only efferent from cortex. यानी कि वो cortex से निकल के आ रहे in the white matter of the cerebellum. They are not going out of cerebellum. They are only coming from the cortex to the white matter. And in the white matter, we have what? Deep cerebellar nuclei. The dentate, emboliform, vestigial, mainly the dentate nucleus. So deep cerebellar nuclei they're coming to. And from the deep cerebellar nuclei, then the efferent fibers will go out of the cerebellum and they are forming the efferent from cerebellum. Ye do alag questions are, guys. Just remember that these are two different questions here. Efferents from the cortex, Purkinje cell. Efferents from cerebellum are formed by deep cerebellar nuclei. The exam में question पूछा हुआ था, they gave the histological view of this cerebellar cortex. They put the arrow on the Purkinje cell and the question was that marked fibers are inhibitory to what? Well, the marked fiber are coming to what cells only? Deep cerebellar nuclei. So they are obviously inhibitory to deep cerebellar nuclei. Purkinje cells are inhibitory cells only. And they are inhibitory to what? Deep cerebellar nuclei and not to anything else because they are not going out of the cerebellum. It's the deep cerebellar nuclei which will send the efferent out of the cerebellum. Which brings us to the question that in the cerebellum, we have three peduncles. The superior cerebellar peduncle, middle cerebellar peduncle, inferior peduncle. What tracts are passing through it? Again, we need to be very smart in this, guys. Just for the orientation, guys, you're looking at the cerebrum over there. This triangle over there is a thalamus. Let's say the triangle over there is a thalamus. And this yellow, green and pink one, these are the peduncles, the three peduncles here. Superior cerebellar peduncle, middle cerebellar peduncle, inferior cerebellar peduncle. Peduncles kya hote hain, guys? The peduncles are the one which are giving passage to the tracts, which are allowing the tract to come in and go out of the cerebellum. Superior cerebellar peduncle is connected to midbrain. Middle cerebellar peduncle is connected to pons, and you can see inferior cerebellar peduncle is connected to the medulla oblongata. That is connected to medulla oblongata. Middle cerebellar peduncle is giving passage to the copy of corticospinal tract, which is called as a cortico. You can see it's coming from cortex to the pons and then to cerebellum. So naam hi kya hua? Corticopontocerebellar tract. It is a copy of corticospinal tract, guys. Corticopontocerebellar tract. It is a copy of corticospinal tract. Despite of only, there's not much of variety there, but still the middle cerebellar peduncle is the largest cerebellar peduncle out of all three, and it is purely afferent. Fibers are only coming inside. bahar kuch nahi ja raha isse. It is only allowing the fiber to come inside. So corticopontocerebellar tract is the only tract, is the only major tract. I mean, as I said, we just need to look at the major tract only. Is the only major tract coming from the middle peduncle. It is purely afferent. You will not see anything going out of the middle peduncle. It is not efferent. It is only afferent peduncle, and it's the largest peduncle. It is afferent peduncle here. Superior cerebellar peduncle, it is allowing one tract to come inside mainly, that is the ventral spinocerebellar tract, the tract which is responsible for unconscious proprioception, ventral spinous, from the spine called spinocerebellar. And then the feedback which is going out of the cerebellum, that is going from the dentate nucleus. One is called as dentatothalamic. You can see going directly from dentate nucleus to thalamus, dentatothalamic. And from dentate to rubrothalamic, via red nucleus they are going. So dentatothalamic and dentatorubrophthalamic tract, they are passing from the superior peduncle. These are the feedback tract, guys. These are the major feedbacks which are going from the superior peduncle. Middle peduncle se ek tract yaad rakhna hai, that is a corticopontocerebellar tract. Superior cerebellar peduncle is giving passage to ventral spinocerebellar tract, and then dentatothalamic and dentatorubrophthalamic tract are passing through this. Or sir, inferior cerebellar peduncle, that is going to the VL nucleus, and the inferior cerebellar peduncle ko kyun yaad rakhna hai? If you know the superior peduncle if you know the middle peduncle, if अगर काम चल रहा है इसमें 3 tracts from superior peduncle, 1 tract from middle peduncle, then guys, why would I read the inferior peduncle here? Why would I do that? Why would I waste my time reading the inferior peduncle when I could do the question just knowing that there are 3 main tracts from superior peduncle, there is 1 main tract from the middle peduncle, and rest everything is passing from the inferior cerebellar peduncle. So if you come across a tract जिसका नाम ही ना सुना हो आपने कभी, if you never heard of a tract like stria medullaris, dorsal spinocerebellar, cuneo-cerebellar, ventral spine, reticulocerebellar, vestibulocerebellar, opposite also, cerebello-vestibular, cerebello-reticular, all those tracts are from inferior peduncle only. So just use your brain, just method of elimination. You need to remember the couple of tracts only and you still get the right answer, guys. This was about some major topics which I believe that from the neuroanatomy are to be done. Now, a little dose of histology after that. 30 seconds break. I will finish in time. Well, guys, this still break going on. I mean, once the class is done, as I said, I'll definitely will be. I need to drive back home also, so obviously I will be answering your queries once I'll reach home or maybe tomorrow morning. But obviously I know that you have other subject to attend tomorrow evening, so I'll make sure that everything is answered before that only. PDF, so I'll share it right away only. And but I need the feedback from all of you guys. I need the feedback from each and every one of you, detailed feedback, because your feedback, I always keep saying that this is something which keeps us going. So whether it is here or on Instagram or any other gram or kilogram, jahan par bhi ho, wherever you are present, just make sure that you give the feedback, and because I want to understand that how beneficial this method of teaching is, so that I can kind of use it more frequently in my YouTube sessions also. Maybe like in the class also I can use a few things like that. Chalo sir, break is over. Sir, the cartilage that you're looking at here, that is a hyaline cartilage. Sir, hyaline cartilage identify karna, it's very easy. Hyaline cartilage, to identify the hyaline cartilage, first of all, just some few features about that. We have a type 2 collagen fiber inside. Hyaline cartilage and elastic cartilage, they have perichondrium. They do have perichondrium, which way we have a fibrous layer. Outer layer is a fibrous layer, and inner layer is the cellular layer. You can see that outer layer is a fibrous layer. ऊपर की तरफ दिख रहा है आपको, and नीचे you can see the chondroblasts are there. That is basically the cellular layer, the inner chondrogenic layer ही बोलते हैं इसको. And this what do you say? The perichondrium is present in the hyaline cartilage, and it is also present in the elastic cartilage here. Fibro में नहीं होता बेटा. Okay. The main feature of the hyaline cartilage is that you see the chondrocytes. The chondrocytes are present in the groups, guys. Chondrocytes are present in groups here, and this cluster of chondrocytes is called as cell nest. That's a unique feature of hyaline cartilage. देखते समझ जाओगे, it's hyaline cartilage. Look at these clusters over there. 3, 4, 3, 4, 3, 4. The patches you can see over there. This is the chondrocytes present in the group, and that is called as a cell nest. And around this cell nest, you can see a darkly stained matrix, and in between you have lightly stained purple matrix over there. So darkly stained matrix is called as a territorial matrix, and in between you have an interterritorial matrix, which gives a different like appearance here. These patches will be seen here. Around the chondrocytes we have territorial matrix, and then in between we have an interterritorial matrix. That is a slide of hyaline cartilage. It's very easy slide to identify here. Romit, I 100% am starting with this 3 question series here. I'll tell you, actually from the few days I was on pause and not able to do that here. Number one, there's a lot of recording is going on right now, and busy at other things as well. There was no break in the classes. I had a class, continuous classes without a break. Every single day there was a class, and moreover I was waiting for this session to get over. Once this session is get over, like now you people have kind of revised the anatomy with me. Now it will be more beneficial if I post those 3 questions every day, which I will do. From tomorrow onwards only, कल से आपको 3 questions मिलेंगे in my Telegram. Every single day till the INICT exam, you'll find 3 important questions in the book. Okay, the next slide here, this is the slide of a elastic cartilage. Now why I'm saying elastic cartilage, again you can see perichondrium first of all. There is a perichondrium there. Same outer layer is a fibrous layer, inner layer is cellular layer. Now this time you will see chondrocytes are present there, but they're not in clusters. There was no territorial, interterritorial mac. Their individual lacunas are there, and there is no cell nest are present in this case. So that is the important thing, that elastic cartilage may, guys, we are expecting to see the elastic fibers, but we will not be able to see elastic fibers in the H&E staining. For that, we need some special stain only. That obviously, I don't think that they're going to give you any special stain or agent stain. That's why when it comes to the cartilages, elastic cartilage is not very likely to be asked. It is a fibrocartilage and the hyaline cartilage. And the fibrocartilage looks something like this. This is a slide of a fibrocartilage. In the fibrocartilage, the important thing to notice, first of all, there is no perichondrin, sir. And number two, we have type 1 collagen fiber. We have loads of collagen bundles are there, parallel bundle of collagen fibers are there. All these are bundles of collagen fibers which are running. And these collagen bundles, they squeeze the chondrocytes in such a way कि सारे chondrocytes line में आ गए. It's like if I just put multiple structures over there and I like with both the hand I squeeze like them. So they all come in the one line only here. So that is the chondrocytes present in a row. Chondrocytes having a linear arrangement is one of the feature of the fibrocartilage. There is a fibrocartilage. I'll share all the links with you guys, my Telegram and Instagram and everything here. And I want you people to flood me. Now it's your turn to flood me with the messages here. But let's get over with this topic. So the last topic that we're going to discuss, guys, for the day is something about the pelvic vessels and the perineum. So again, it's about the percentage of questions. I'm not saying thorax se kuch nahi pooch sakte. They will not ask anything from thorax. But you can kind of, if in your one-shot revision or in a quick recap program, you can keep thorax out of your preparation part. In the abdomen also, cut it down to mainly to the perineum part, because perineum pe OBG obviously is asked heavily in the exam. Perineum questions are definitely are, and even in my regular class also I say that here perineum is the most important topic to be paid attention to. Okay. Now first thing, guys, we'll discuss a little about this internal iliac artery here. Now again, if you've read about the branches of internal iliac artery, nothing like that here. Anterior division, posterior division, just to understand that what they are supplying, where they're going. For the understanding, that is okay. Right now, I'm talking about from the exam point of view. Internal iliac artery, that is internal iliac artery looking at, it is dividing into this posterior division. Look at this posterior branch here. And this big division over there is anterior division. Posterior division of internal iliac artery gives off 3 branches, and that is the lateral sacral artery, the one which I'm encircling. We got a superior gluteal artery, and it's a iliolumbar artery over there. It's the posterior division, guys. Posterior division, which is giving off 3 branches, and the branches are also very much posterior. Look at the branches. It says iliolumbar. Lumbar piche hoga na, iliolumbar artery. Lateral sacral. Sacral is also posterior. Superior gluteal region. So the branches coming from posterior division are 3. The posterior division branches are 3. That is superior gluteal, iliolumbar, and lateral sacral artery. It's a very commonly asked question that what are the branches coming from anterior division, what is the branch coming from posterior division. And trust me, I have seen this question. I can recall this question all the way back to 2008, 2010, 11, 12, 16, 17. पूछते रहते हैं इस question को. Internal iliac artery की which branch is from anterior division, which branch is from posterior division. As I said, if you read about the anterior branches, superior vesicular, inferior vesicular, the vaginal artery, uterine artery, middle rectal, internal pudendal, inferior gluteal, all these arteries obviously are coming from the anterior division here. But from the MCQ point of view, if you know the posterior division branches, the 3 branches over there, then again, why you need to review the anterior division? From the exam quick revision point of view, just remember 3 branches from posterior division, anterior division. Again, why should I? अगर क्वेश्चन उन्हें यही पूछना है बार बार कि which branches are from anterior, which branches of posterior division. So if I know the posterior division branches, I automatically know everything is from the anterior, as rest everything is from anterior division only. Whatever is not coming from posterior is from anterior division itself. That's what है ना, आज का मेरा थीम यही होने वाला था. Why should I? Why would I do that? Why should I do this? Why you would do this? No need to do that. Okay, sir. Now let's come to this topic, the last topic, but the topic which we need to discuss in detail, because we know that there are almost 100% chances, almost, that to get at least one question from this part, and that is a perineum part here. So I'm going to take like whatever time, 15, 20 minutes, whatever it take, maybe not that much, to complete this topic, the perineum. And let's start the perineum, guys, the understanding the perineum from the pelvic diaphragm. Okay, here we go. Now pelvic diaphragm, you're looking at the pelvic diaphragm from the inferior. Let's say if there's a pelvic diaphragm for me, if you're looking at the pelvic diaphragm like this, agar maan lete, this is the pelvic diaphragm for me here like this here. The pelvic diaphragm is the highest structure in the perineum. And then we'll just need to keep the building perineum downward. If this is a pelvic diaphragm, whatever picture or images I'll show you in this way, guys. Like in the lithotic position, you're looking at the pelvic diaphragm and you're seeing it from the inferior aspect. That's how you're going to look at that. Okay. This is a pelvic bone. And here is a ischial tuberosity. There's a sacrum bone over there. And that's a ligament called as sacrotuberous ligament. There is a sacrotuberous ligament. Pelvic diaphragm is a combination of three muscles coming from three different parts of the hip bone. One is coming from pubis, that is called as pubococcygeus. One muscle is called as iliococcygeus. And one muscle is called as ischiococcygeus or simply coccygeus. So three muscle over there, that is a pubococcygeus, there is a iliococcygeus, and there is a ischiococcygeus. And all these three muscles together are called as a pelvic diaphragm, guys. Three muscles together are called as pelvic diaphragm. But out of these three muscles, ischiococcygeus muscle, in human being, this muscle is of not much use. It's kind of vestigial muscle. That's why only pubococcygeus and iliococcygeus together are called as levator ani. So when it comes to levator ani, only two muscles are counted there, that is pubo and iliococcygeus, because these muscles are capable of elevating the anal canal. Iliococcygeus and pubococcygeus can do that. Ischiococcygeus is a muscle for the movement of tail. We don't have tail. I mean, obviously, this muscle is not required for this. We don't have to wag our tail in front of anyone. So, ischiococcygeus muscle is a vestigial muscle in human. It is forming a part of pelvic diaphragm, but it is not the part of levator ani. Now, let's say if this is a section of female perineum, guys. Let's say, guys, we have this is a section of female perineum. What you'll see that there are three openings there: the urethral opening, the vaginal opening, and the rectal opening is there. Urethral opening, vaginal opening, rectal opening, the muscle which is present closest to them is the pubococcygeus. So we have muscle like the extension of pubococcygeus will cover them. So there is a muscle called as the pubococcygeus. There we go. Then we have muscle iliococcygeus. I'm sorry, what do you say? Pubovaginalis, I'm sorry. That is pubourethralis, I'm sorry guys. That is pubourethralis covering the urethra. That is pubovaginalis. And there is a puborectalis muscle which is covering the rectum. So the three muscles which are the modifications of the pubococcygeus here. The modification of pubococcygeus involves what? Pubourethralis, pubovaginalis, and puborectalis. Especially puborectalis is very, very important because this muscle maintains the anorectal angle. It maintains the angle between the rectum and anal canal, and that's why it is also called as muscle of continence. It is also called as a muscle of continence, right? So that is, you all started. So if you're looking at the pelvic diaphragm from below, that's a first layer, guys. That's a first layer done. You're looking at the muscles forming the pelvic diaphragm, which part is levator ani, and then the three modification of pubococcygeus. Chalo, iske niche aate. Now let's go further below that. The more I say we go below, we are going downward. That means we are going superficial, guys. Hum deep se superficial ja rahe. We're going from deep to superficial. So again, the views from inferior side only. The views from inferior side, same boundaries, same here. Now there is another diaphragm present there, and this is called as a urogenital diaphragm. There was a pelvic diaphragm. Below the pelvic diaphragm, that's a pelvic diaphragm. Below that there is a urogenital diaphragm, and you're seeing it like this. So that's a pelvic diaphragm there, and this one is a urogenital diaphragm. And what you're looking at right now is an inferior layer of urogenital diaphragm, guys. Inferior layer. It is an inferior layer of urogenital diaphragm. There are two layers. दो layer होती है urogenital diaphragm में. One is superior, one is inferior. We are not looking at the superior. We're directly looking at the inferior layer of urogenital diaphragm, which is also called as perineal membrane. This inferior layer of UGD, urogenital diaphragm, which is also called as a perineal membrane. So in total, actually, we're done with three layers. First was the pelvic diaphragm, then it is a superior layer of urogenital diaphragm which we did not see, and then we have an inferior layer of urogenital diaphragm, that is a perineal membrane. Below perineal membrane, let's say this is the bulb of the penis covered with a muscle called as a bulbospongiosus, and that is the crust of the penis which is covered with a muscle called as a ischiocavernosus, guys. Bulb ke upar jo muscle hai, that muscle is called as a bulbospongiosus because the same muscle will cover the spongy urethra also. And the muscle present on the crust is a ischiocavernosus. Muscle is called as ischiocavernosus. And there also is a muscle which is running transversely in the perineum, which is called as a transverse perineal muscle. And because this muscle is present below the perineal membrane, that's why you're able to see, this is called as superficial transverse perineal muscle. This is below the perineal membrane. That's a superficial transverse perineal muscle. Guys, please look at this once again. Let me do that again here. So what I'm saying is, there is a superior layer and inferior layer of urogenital diaphragm. Below inferior layer of urogenital diaphragm, we have, this is the inferior layer of perineal membrane. You can call it perineal membrane also. There is a Bulb of the penis called as bulbospongiosus. I mean, in female it is bulbovestibule. Muscle is same, only bulbospongiosus. And then we have a ischiocavernosus, which is covering the crust of the penis. And we also have a superficial transverse perineal muscle as well. So guys, if I start counting from the top, like right now you see in the lithotomy position, अगर आप ऊपर से देखेंगे तो pelvic diaphragm, superior layer of urogenital diaphragm, inferior layer of urogenital diaphragm, and then we have this bulb and the crus and all these muscles are there, right? Bulbospongiosus, ischiocavernosus and all that. In the posterior triangle, what we have here is anal canal. That is the anal, the superficial, that's the anal canal there. And this anal canal is covered with a sphincter that is called as the external anal sphincter, guys. That sphincter over there is the external anal sphincter. That is the external anal sphincter. And that point, which is you can see indicating over there, guys, this is the junction of most of the muscles in the perineum, the fibromuscular node, which is called as a perineal body. That is called as a perineal body. So guys, before we see what muscles are contributing to perineal body, like let's have a look at the picture, an atlas image to kind of correlate with this. I hope you understood this image. Let's try to correlate with the atlas image here. There we go. Now I hope you can see that first thing, that's a pelvic diaphragm here. This one I'm showing, that is all pelvic diaphragm there, this one. Below pelvic diaphragm, this is a urogenital diaphragm. Like we coming below, that is a urogenital diaphragm. Which layer of urogenital diaphragm is that? That is the inferior layer, also called as a perineal membrane. Muscle bulbospongiosus, muscle ischiocavernosus, muscle superficial transverse perineal muscle, and that is an external anal sphincter. That is an external anal sphincter. And this here is the perineal body. Look at this fibromuscular node over there. That is the perineal body, guys. That is a perineal body. The question is that what muscles are contributing to perineal body, guys? If let me bring that picture back to you. Perineal body is made up of 10 muscles. And in these 10 muscles, 4 are paired muscles and 2 are unpaired muscles. So 4 paired and 2 unpaired. What paired muscles are there and what is the common mistake we do? The paired muscle is superficial transverse perineal muscle, obviously. If you have a muscle called as superficial transverse perineal muscle, there must be a muscle called as deep transverse perineal muscle will be there. Okay, ये भी हो गया, deep transverse. Then the bulbospongiosus, that muscle is there. And the fourth muscle is the one जो usually people get it wrong here. It's not ischiocavernosus, guys. How can we have ischiocavernosus? How can we have this muscle, this one, the ischiocavernosus muscle in the perineal body? The muscle is far away. It's like anterolaterally placed. You cannot have that muscle in the perineal body. So it's actually levator ani. It's the levator ani muscle which is a paired muscle contributing to perineal body. Superficial transverse perineal muscle, deep transverse perineal muscle, bulbospongiosus and levator ani, and not ischiocavernosus, guys, and not ischiocavernosus. Unpaired muscle, central muscle like external anal sphincter, and we have some longitudinal muscles also in the anal canal that is also contributing to it. Longitudinal muscles of anal canal is contributing to it. So 10 muscles, guys, that is 10 muscles contributing to perineal body. You're very careful in the perineal, especially in the episiotomy, guys. If you do the episiotomy posteriorly, then obviously perineal body can get injured here. If the perineal body, what is just behind the perineal body? External anal sphincter is there. The next thing which can get injured directly is the external anal sphincter. So in the posterior lateral episiotomy, we make sure that perineal body is spared and only the transverse perineal muscles are compromised in that case. Because it's a junction of 10 muscles. So if the perineal body is injured, obviously that can lead to the prolapse as well. Okay, now this is the moment of truth, guys. Now we look at the whatever layers we discussed. Let's look at those layers in the side view. Like it's like if I take a sagittal section of the perineum, the first layer, the second layer, the third layer, the fourth layer, like this. Like let's understand the layer like that here. The first layer is the highest layer. Javed, you're right. This is the pelvic diaphragm. It's a sagittal section, guys. Let's say I'm facing this side. That's a pelvic diaphragm. Just below pelvic diaphragm is a superior layer of urogenital diaphragm. Below that we have inferior layer of urogenital diaphragm. And superior layer of urogenital diaphragm and inferior layer of urogenital diaphragm, they are fusing with each other anteriorly and posteriorly. This is pelvic diaphragm. This is superior layer of UGD, and that is the inferior layer of urogenital diaphragm, which is also called as perineal membrane. This red line over there is corresponding to perineal membrane. And you can see this superior layer and perineal membrane, they are fusing anteriorly and posteriorly. Below perineal membrane, because it is a mid-sagittal section, the section will go from the bulb and the shaft of the penis. So there we have this bulb and the shaft of the penis. And here is the urethra. That's the urethra passing through, right? That's the bulb of the penis, and that's the urethra you're looking at here. Now, to understand that what is the floor of this region here, guys, on the anterior abdominal wall, you know the anterior abdominal wall is having a fascia called as a Camper's fascia and Scarpa's fascia. Scarpa's fascia present on the anterior abdominal wall. The same Scarpa's fascia will continue in the scrotum in the form of dartos muscle, and the same dartos muscle will continue behind as the Colles fascia. This is the dartos muscle there. That is the dartos muscle, and that is the Colles fascia which is merging with the perineal membrane only here. So Scarpa's fascia continues as the dartos muscle, and dartos muscle will continue as Colles fascia. And the moment you put the Colles fascia here, now we have the two pouches, guys. This space over there is a deep perineal pouch because it is above. And this page below here is a superficial perineal pouch. The two perineal pouches, superficial pouch and deep pouch. Deep pouch is above and superficial pouch is below. Deep perineal pouch, it is not wrong to say that deep perineal pouch is present between the two layers of urogenital diaphragm. Or you can simply say the space inside the urogenital diaphragm is the deep perineal pouch, whereas the superficial perineal pouch is present below the perineal membrane. So you write only that perineal membrane separates the deep pouch and the superficial pouch. Upper deep pouch and niche superficial pouch. Knowing that this is a deep pouch and superficial pouch, guys, let's take it one step forward here. Okay. About the extra vestige of urine. This urethra here is the membranous urethra, and this urethra here is a bulbar urethra. Now let's take it to the next page here. That's the membranous urethra. Any injury to the membranous urethra, any rupture of the membranous urethra, the urine will accumulate in what pouch? In the deep perineal pouch only. Injury to membranous urethra, urine goes into the deep pouch. But if the injury is to the bulbar urethra or spongy urethra in the bulb of penis, the urine come into the superficial pouch. Unfortunately, superficial pouch anterior wall is deficient. There is no anterior wall. So actually urine can go into the scrotum also. And this dartos layer is a continuation of the Scarpa's fascia. Urine can go behind the Scarpa's fascia in the abdominal wall all the way to the axilla. And it can go downward into thigh as well. So that's a different story altogether. When the injury is to this pouch, to the bulbar urethra, urine can go into the superficial pouch, it can come into the scrotum also, it can go on the anterior abdominal wall, and it can go downward into thigh as well, guys. So that's the main thing here, that if the question is asked, what will happen if the membranous urethra is injured? Urine accumulation, deep perineal pouch. What if the injury is to the bulbar urethra or spongy urethra in the bulb of penis? Superficial pouch, scrotum, anterior abdominal wall, upper part of thigh, and that is because there is no anterior wall. There is no anterior wall of superficial perineal pouch. That is the reason. Contents of deep pouch and superficial pouch, you should not bother much about that, guys. Superficial pouch, whatever we saw, guys, in this picture, if I just take you back for 1 second, look here. These are all, these are all content of superficial pouch only. Everything which is present below the perineal membrane, they are all contents of superficial pouch. Bulbospongiosus, ischiocavernosus, superficial transverse perineal muscle. And especially remember one thing, that female gland is present in the superficial pouch and male gland is in the deep pouch. Because see, there is a external urethral sphincter here, and there will be the bulbourethral gland. The Cowper's gland upar hota hai, but Cowper's gland is here in the deep pouch. In female, the Bartholin's gland is in the superficial pouch. The two major content to remember, that Bartholin's gland is present in the superficial pouch, and the male gland, the Cowper's gland, is present in the deep pouch. And finally, coming to our last topic, that is the ischioanal fossa or ischiorectal fossa. Chota sa topic hai, but again very important, guys, and the questions are very, very frequently asked from here. Ischiorectal or ischioanal fossa. The reason we call it ischiorectal fossa, because here is the ischial tuberosity. Look at my finger here. That is on the ischial tuberosity there. And this is anal canal, or you can say rectum and anal canal. So fossa in between is called as the ischiorectal fossa or ischioanal fossa. In the ischiorectal fossa, if I just replicate that picture over there, that is anal canal. This is the skin, like this. Let me just keep on corresponding. That is the skin or forming the base of the ischiorectal fossa. That is the skin over there. This is the skin over there, guys. That is the base of the ischiorectal fossa. And lateral boundary of the ischiorectal fossa is by this muscle. Look at that muscle over there. That is muscle is the obturator internus. That muscle over there is the obturator internus muscle. This is the obturator internus muscle, which is forming the lateral boundary of ischiorectal fossa, obturator internus. Whereas sphincter, external anal sphincter like here, and the muscle levator ani, pelvic diaphragm, are forming the medial wall. That is external anal sphincter. That is external anal sphincter. And then we have this levator ani. That is a levator ani or pelvic diaphragm. That is the one which is forming the medial wall. So guys, levator ani, or you can say pelvic diaphragm. So lateral wall is by obturator internus. Medial wall dono se ban raha hai, by external anal sphincter and levator ani. And you know, obturator internus muscle is having a very thick fascia covering it from inside called as a obturator fascia also. There is an obturator fascia as well. Okay. Obturator fascia, this obturator fascia, it forms a canal very much on the lateral side of ischiatal fossa, and this is called as a pudendal canal, also called as Alcock's canal or pudendal canal. I'm sure आप सबने OBG में पढ़ाई होगा, or Alcock's canal. When you the pudendal nerve block, when you do, it's in this canal only. This pudendal canal is holding the pudendal nerve and internal pudendal vessels, guys. Pudendal nerve and internal pudendal vessels are the content of this here. In the ischiatal fossa, the main content of ischiatal fossa here will be fat. Look at this, all fat, everything is fat over there. And what you have on the lateral side, the obturator fascia, mainly the obturator fascia forms this canal called as a pudendal canal, and which is having a pudendal nerve and internal pudendal vessel present inside. If I show you the ischiatal fossa content from the inferior aspect, if I see it from below, guys, see, ischiatal fossa content to be seen from inferior. First of all, fat is there. Fat is there, number one. Number two, pudendal canal and its content is there. Pudendal canal content is there. Now, let me put the third content very carefully. This is a picture in which you're looking at the pudendal canal. Just a schematic representation. It's not a very accurate representation, guys. That's a pudendal canal, like more toward the lateral side. This fossa here is a ischiatal fossa only, and that is a pudendal canal. We said pudendal canal, it allows the pudendal nerve and internal pudendal vessel to go anteriorly like this. Pudendal nerve will pass through it, and internal pudendal vessel will pass through it here. These structures are very much toward the lateral side, so they are very, very safe. They're very safe. If there is an abscess in the ischiatal fossa, guys, first of all, I hope you know that one ischiatal fossa abscess can easily go into the another one behind anal canal, called as a horseshoe abscess or horseshoe recess. एक ischiatal fossa से दूसरे ischiatal fossa में the abscess can go easily because behind the anal canal. Not in front. In front we have perineal body, but behind anal canal it is possible that from one ischiatal fossa the another ischiatal fossa can receive the abscess. The pudendal nerve and internal pudendal vessels are very safe in the ischiatal fossa because they are very much toward the lateral side. So if you put an incision in the ischiatal fossa to drain the abscess, they will not get injured here. What will get injured here is one nerve and one blood vessel which is crossing the ischiatal fossa horizontally, and that is called as inferior rectal nerves and vessels. Inferior rectal nerves and vessels are the contents written over there. Inferior rectal nerves and vessels are the content which are running horizontally, and they are the one, artery and nerve both beta. Artery also, nerve also. Okay. So that is the one which can get injured in the ischiorectal fossa abscess. So when we drain the ischiorectal fossa abscess, this is something which can get injured. So this is about the ischiorectal fossa abscess. 11 guys is considered lucky for you people. I've finished my session with 11 here. This is what I had in my kitty to serve you today. Invest in your dream. Grind now, we will shine later. Grind like this, gentlemen. I'm still very energetic right now. I couldn't go for hours and hours the way you people have responded in the group here. बेटा ischiatal fossa and perineal membrane कोई relation ही नहीं है इसमें. Ischiatal fossa is posterior, perineal membrane is forming the anterior wall actually. Wow, we're already sending some great pictures. Thank you guys. Thank you so much. Thank you. Really, thank you so much. I mean, this is my job to teach you people. Obviously, I have to sit here and teach you guys, but it takes a lot from your side also. This is a commitment. This is a process I was talking about in the beginning, that this process that you sitting over there, hearing everything, trying to absorb as much as you can, trying to learn everything that you, trying to ask the queries, being part of it, like laughing with me and, you know, just basically being a part of this session is what all is needed. Keep doing this same process with every subject. No matter you find it very interesting, you find less interesting here. Karna to hai yaar. We have to do it here because the next time when I'm meeting you people, I really wish to meet you all somewhere in the life. First of all, whenever we get to meet anywhere, okay, do not hesitate to meet. I've seen people meet at airports and hotels and other places here. But what people does, they don't come and greet. Sometimes they are shy on something else here. If you find me anywhere, please do come and at least say hello. I will be really, really happy to do that here. Okay. And as I said, I really hope that next time we are meeting, like I'll be sitting like this on the chair here. You'll be sitting on the other side of the chair. And the question I'll be asking you is like, okay, where did you attend the anatomy class from? How you get this such a great rank? So things like that. Well, guys, bless you all. You just, as I said, I know this is a time which is a little stressful for everyone, but there's only two way out here. Either we grind through it and churn this, this milk and convert it into butter and come out of it, or we can just drown into this. So I'll rather choose the first one. So thank you so very much for your time and being the way you were and being so respectful, so nice and so funny. I'll be sharing my Instagram and ID and YouTube ID and everything with you. Please do write your reviews, good, bad, whatever critics. I'm open to everything over here. Thank you so much and bye-bye. All the best.
Alright guys, so I hope this one shot program was very useful for you, है ना? So can I say that the entire subject was revised in a very quick amount of time? But as I told you earlier, this is not the end. Now what you have to do is, you have to attempt the test. And how will you attempt the test? You have to download the Egurukal app if you have not done it. And in this Egurukal app, go to the test section. In the test section, go to the QR test. And in this QR test, you will see the test of this subject. Click on that test, gallery or camera. They will ask for a QR code, and here is the QR code. Scan this QR code or download it and put it into your gallery, whichever option that you want, and you are good to go. Please make sure that you are not finishing your day without attempting the test. I wish you all the best for the test as well as happy reading, and I am sure that you will reach to the success in the exam ahead. Take care and God bless you all.